On this special episode of the ASC Podcast with John Goehle, we visit the New York State Association of ASCs 2023 annual conference held October 4th through the 6th, 2023 in Albany, New York, and we interview various speakers and the leadership of the association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 202 of the ASC Podcast with John Goehle for October 4th through 6th, 2023, recording from our mobile studio at the Desmond Hotel in Albany, New York, during the 2023 New York State Association of Ambulatory Surgery Centers annual conference. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by the relevant regulatory bodies. And joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry. He is a sought-after speaker on regulatory accreditation and finance issues.
So we're back home. We're actually recording a couple weeks after the conference because we had some problems with the editing. I think this is the most interviews we've ever done for a conference. I think there's 10 interviews here, if we're able to include all of them. So it was a great conference and probably one of the best, one of the nicest venues at the Desmond Hotel in Albany. A place that has just gone through a major renovation. Really great conference space, and we were given a room that was labeled the studio to record from. So it was a great room. We brought our full-fledged mobile studio, and we recorded from there. But this section, at least, is being recorded from our home studio. So you'll probably notice a difference in the quality of the interviews as compared to what we're recording right now. But we do want to thank everybody at the Desmond Hotel, as well as all of the people at the New York State Association. And they did a great job pulling together this conference. It was probably, it was a record-breaking attendance and record-breaking number of exhibitors. And I will say I had a lot of fun. There was great food. There was a lot of socializing with other members. We, Ambulatory Healthcare Strategies, had a very large presence, including the podcast there. I think we had, was it about 14 or 15 people?
I think so, yes. Yep.
And indeed, we even had Christina Benton, one of our dear friends who you see and hear periodically on the podcast and some of our virtual conferences. And then we also did a pre-conference. Ambulatory Healthcare Strategy sponsored, and the podcast sponsored a pre-conference on the Wednesday before the conference actually kicked off. We had an annual client meeting in the morning, and in the afternoon we did 3 presentations with AEU credits. So you could get another 3 credits if you were there for the pre-conference. And during the pre-conference, we had a session from Lori Rodericks on infection control. Christina Benton did a section on HIPAA. It was talking about some of the current issues in HIPAA. Something we had talked about, Sue. Remember the whole issue of our Alexas and our Siris listening to us and perhaps causing a HIPAA problem.
Yep. And poor Christina, because there was some sort of a test. I don't know if it was a New York State emergency broadcast
yes.
or whatever it was called.
No, it was a national,
national thing. So everybody's cell phone went off kind of sporadically, was paced out over a few minutes during her session.
She thinks that I did that on purpose
good
for
planning,
her.
John. Yes.
And then
that was a really good talk.
Oh, it was good. And as we talked a little bit about that, and I think, Sue, we should try to get her on one of our podcasts to talk about HIPAA. It's one of those areas that we tend to ignore because we think everybody knows about HIPAA, and that was one of the things she had actually brought up during the conference.
Well, like you said, as electronics become more of a thing, and just as everything changes, I feel like with infection control, we always feel like there's new information and we're learning new things, and people don't think of HIPAA that way, but it is.
Right.
There's always new things you have to be aware of.
Right. Especially, as we well know, my watch sometimes talks to me, and I don't even know how I get it to talk to me. And then I did a presentation about recent trends in accreditation and surveys, and I made a record for myself. Usually I go 5 or 10 minutes over, but I went 45 minutes over on that presentation. So I don't know if that's a good record or a bad record, but no one laughed except to go to the bathroom. Of course, those that went to the bathroom never came back. But
you're sticking with that story.
I'm sticking with that story, yeah. But we ended up being kicked out because there was another group in afterwards. But it just shows how much we really didn't have strict deadlines there because I was the last speaker, and people really wanted to talk about what's going on in the accreditation world. And we're going to talk about that a little bit in the podcast, too, that there's a lot of things going on in accreditation. There's a lot of options now that we didn't have before. And, of course, a lot going on with surveys. We had a lot of good presentations. I did 3 sessions, which I didn't. So I didn't interview myself. So I'll just mention mine before we get into the actual interviews. But we had a panel discussion that I participated in about what it takes to build a successful future together. Talking about the future of ambulatory surgery, and from a perspective of an owner of a surgery center, from a regulatory perspective, as well as from the perspective of the association and what it can do for our members. And then we had a panel discussion about the association's quality committee activities. I'm a member of the quality committee, and I moderated a session with the members of the committee where we talked about our first quality benchmarking study on wait time. And we're in the process of publishing the QI study template that we've prepared for centers to use as part of the QAPI program. It seemed to be quite a bit of very positive feedback on what we presented. We haven't sent it out to anybody yet because we're still fine-tuning it. And then we had a lot of great feedback on some potential future QI studies and benchmarking studies. So stay tuned if you're a member of the state association. And then I did a presentation on Article 28 regulations where I outlined all of the relevant New York State licensing requirements for ASCs under the Article 28 regulations. And I'm thinking about doing a virtual conference for other members of the on this presentation, perhaps a little longer to cover the topic better. It really was very cramped to talk about the breadth of these regulations in only a 1-hour format. So we're going to see if we can do that and make that available again to members of the state association. So our first interview was with John Van Valkenburg, the president of the state association, and Jeffrey Flynn, the vice president. And they talked about the association and membership and the legislative achievements. And by the way, Sue, Jeff, when we interviewed him, did not know that he was about to receive the Lifetime Achievement Award this year. And so it was interesting. 3 of us in the room when we were doing the interview had been previous and current award winners. So John got it in 2021, I got it in 2022, and now Jeffrey got it in 2023.
And none of you knew ahead of time.
None of us knew ahead of time.
Surprise,
apparently you knew, though, when I got it last year, because you had to make sure that I was going to be there, I guess.
Like you would ever miss this association meeting. It's so important, but yes.
Yeah, and Jeffrey he's been really quite instrumental in rebuilding the conferences, and he was certainly deserving of it, and we appreciate all the hard work he put into it. So let's listen to that interview. It is October 2023. I'm here at the New York State Association. We're just kicking off the New York State Association meeting in Albany, New York, and I have my dear friends John Van Valkenburg and Jeffrey Flynn, president and vice president of the New York State Association. Welcome to the podcast here, and we haven't even really started the conference yet, and we have you here to talk about what's going on. So, Jeffrey, why don't we start with you? Talk a little bit about the program, about the everything that went into the event here in Albany.
Yeah, this is our best attended conference ever. We have the most exhibitors we've ever had, but the program we wanted to offer to the our members was the future. We wanted to talk about future procedures, threats that go into surgery centers today that we have to challenges we have to face, and kind of facing it all together. And the program is set up to have those discussions as we go through. Right.
And as you said, this is the biggest conference we've done. I mean, the organization's 34 years old now, 33 years old now. And we're back to Albany. We used to be here quite a bit. What do you think, why is it important to be here in Albany?
I think the difference this year is we transformed to one annual conference because we do want to really focus on our regions working together. And I think just Albany seemed to be the perfect center of place to come back to.
Right.
And this place really worked out well for us, the Desmond.
Yeah, the Desmond, of course, I've been coming here when I was the president. This was one of our main sites back in the 90s here. John Van Valkenburg, you accepted the presidency again. I don't know if accepted is the right term. But congratulations on being remaining the president here. Tell me about what the last year has been as president of the State Association. You claim to work for a surgery center, but I hear more about your work here than in the surgery center.
Yeah, it's been another challenge. It's interesting. It's like another year, another challenge.
Yeah.
Obviously, the past several years being the president of the organization have been a challenging, and there was always the big focus on COVID, right? And there was a lot we did around supporting facilities with that. And now, unfortunately, it seems like that's having some effect on us again. But now there's all these other challenges that have presented, the staffing. Staffing challenges have been huge recently, and not just staffing, but escalating costs.
Right.
And a lot of that revolves around staffing and staffing shortages, escalating costs. And then one thing that's really become, and we're going to talk about it at this meeting, but anesthesia. Yeah. It's really become a crisis. And I think a lot of us, myself included, in my role as a facility, just did not see it coming. At all. I mean, of all the challenges, that we were expecting, and there's been all this optimism, and I'm still cautiously optimistic about a lot of things that are going on in this industry and in this space, but just kind of got hit out of nowhere with that. And it's proven to be a big issue because, and not to get too far into it, but the margins in surgery centers, because of our reimbursement, and, they've always been, good, but because we're efficient, because our costs are controlled, and with staffing costs increasing, and now, having to support anesthesia in a facility, the margins aren't there to do that. So it becomes this unique business challenge. Like the whole model has become challenged of an ASC. To be honest with you, that's how I feel, anyways. And I think it's going to have to be figured out somehow, because it's creating a crisis, not just for ASCs, but for healthcare in general, access.
Yeah, and you brought something up earlier, and we talked about this at the board meeting yesterday, that which really gets to the heart of why we're here and what we're talking about and why it's important to be a member of the State Association, is that this anesthesia crisis, it was brewing, right? And then it became a crisis. It wasn't like a slow burn up. It was, okay, this was a problem, and then suddenly it became a crisis. Right. And we had to react very quickly. On our program committee, for example, we immediately, sought out some of the major speakers to talk about different aspects of that. But talk a little bit about how, both of you can talk about how important it is, to the membership to have access to a resource such as the New York State Association, to be able to suddenly discover that you might have a problem coming, and then what you do about it.
The big shock I had is John and I went to the fly-in in Washington for the lobby-in in Washington in February. Yeah. I hadn't heard of the anesthesia crisis, and that it had hit him just right smack. Yeah. And then when I got back, by June, it hit me.
Right.
So it really did happen exactly as you're saying. And it's important to be part of the organization, because it's those kind of conversations start a heads up, and what can we do to mitigate the threat that's against us with anesthesia crisis.
Right. And not just, so there's a couple of parts to that. It's, being able to identify those problems or those issues coming, because again, when we're networking, when we're talking, when we're having these events, when we're having our biweekly phone calls, when we're having some of the other things that I'm sure we'll talk about that we've gotten into as an association. But, you learn from each other. And then you also lean on each other and help solve challenges that we each have. I mean, we all have unique challenges to our own facilities, but there's a lot of challenges that we all share. And, I know you know this, John, and probably anybody that works in an ASC is very acutely aware of this, but we don't always have a lot of resources.
Yeah.
A lot of times it's kind of us, and sometimes it feels like it's just us and we're alone. But when you're involved in the association, when you're coming to these meetings, it's really not. I mean, you have all these colleagues, that you work with, that you talk to on a regular basis, that if you're having a problem, you can reach out to them and say, hey, are you having this problem as well? What are you doing about it? And that's really what's been great about just being involved in the association and now becoming a leader of the association. I mean, I really, this is the first time we've gotten together as a state in a year since we've gone to one annual meeting. And it's interesting. Some of these people, we talk to them regularly, but this is my first time seeing them in a year, and it's it's like a reunion. So
it's like we hadn't been apart.
Yeah, and it's really nice to see everybody in person and come to the meeting. And again, I'm happy to be here. I'm really excited about the event. Like you said, we haven't really gotten started yet, but we're kicking it off this morning, and I'm just really looking forward to it.
Of course, we've been here for 2 days, so it seems like we've
been here already.
We've been, and so that camaraderie part. I mean, the conference. I'm chair of the education committee, and we're all three of us are involved in the conference committee here. The conference material is extremely important, but there's a lot more going on here during the event. That's important. And a big part we just talked about is, getting to know your colleagues, turning to the person next to you when you're, sitting, waiting for a session to start, and at lunch and at dinner and, whatever. Those conversations are extremely important because those people become, valuable resources to you in the future.
Absolutely.
And that's why we want to really focus to get people in the regions to really know their neighbors, because it is key that this conference, 90% of the people attending this conference, this is the only conference they're going to.
Right.
The only time they're able to get out of their silo and really get educated by talking with our fellow members, but also educated by the exhibitors.
Right. And let's talk about the exhibitors, because that's another important part of it. They're not just here trying to sell a product. They're trying to solve solutions.
Solutions for all of us. And it's great. The number of vendors we have 45 vendors here this year. That's the most we've ever had. They come from all different walks of the medical field and different solutions. So therefore, I think there's a lot of opportunity for people to be educated today. There's one company here has been a resource that I know our centers have used, the ever-ending Sparks report that we always feel is a big thing. There's a company now that actually can help us do that, and is now showing up at the conference and being out there. I'm proof that they actually have removed one headache from me.
Right.
So, I mean, it's just resources like that. If we can kind of focus and educate each other about those resources and what's out there, because again, as we're talking about staffing issues, there are certain things now we're looking at outsourcing is now no longer an option.
Right.
We're having to do it because not getting staff for things.
And with regards to the exhibitors, another thing that I'm happy about and have been really pleased to see is, this is the most ever. So obviously we have a lot of new ones, but the same ones keep coming back.
Right.
So, and we're happy to have them, and they're obviously happy to be here. And, they've found this event to be valuable to them, that they're willing to support it. So, we certainly appreciate that. And again, it makes me happy that, we're not having to go find new ones every time, that it is a mutually beneficial relationship.
And we know that we have a lot of listeners that are vendors here. When I was in Ohio, a couple people came up to me and said, how do I get in to the New York State Association meeting? Because we sell out, frequently. I mean, we keep expanding the number of options that are available. But my advice to everybody, and I'm sure your advice is to, call Jeffrey tomorrow. And because we're already planning for next year,
absolutely.
And of course there's opportunities throughout the year now with these regional meetings. So the state is broken down into what we call regions. And there are leaders on the board in each of the regions that put together, regular, I would say periodic meetings that eventually become regular, but it's been an experiment, highly successful experiment.
throughout 2023. They're on a little bit of a hold right now because, of course, we got this big conference. And but as soon as we're done here, I know in the Western region, we're party animals out in the Western region. So, we'll be getting together very shortly to plan the next one. So talk a little bit about those regions and the importance and how everybody can participate in them.
The centers can actually participate, but as we've talked about, now we want to make it educational opportunities for the rank and file that can't come to the conferences, whether doing virtual things at the end of the day that actually give our staff education and give them a certain meaning that you're part of a bigger process going forward and the importance of their job and the education. And then perhaps also just going in to see other centers. What I did notice, and I was speaking this morning about, is that I noticed the most successful of our regional events has been when they've been hosted in a surgery center, because all of us are very interested in going into other centers just to seeing them. And I think that during the next year, that's something we should be encouraging, to have those, each center kind of do open houses in their regions so that we get to know each other and then rely on each other. In New York City, it just happens to be easier, we're condensed, but there's, to be able to call up and borrow something, or to be able to
valuable.
Get a policy because it's very specific to New York, and just to be able to call somebody and know that they're not you, they're your colleague, they're not your competitor. They want to help you out. They want to, when you do better, they do better.
And we always want to get more physician participation in the state association. We have more physicians here than we've ever had in the state association.
We have 5 CON holders here. So that's amazing that we've had that many. And you'll see that they now are seeing the importance to do it. And getting them to talk to the other owners to see how it's important to belong in the organization is essential.
And we're actually going to interview 2 of them during this thing to get their view of what is important to them and what they're looking for here. And my point about bringing it up when I talk about regionals is that the doctors love seeing the other surgery centers.
Oh, absolutely.
So if you want to get doctors to participate, tell you're going to do it at their competing, or let them be the host and show off their site. Lastly, let's just talk a little bit about the other activities that don't happen during the conference and during these regional meetings, because this organization is meeting on a regular basis. John, why don't you talk a little bit about our regular conversations?
Yeah, absolutely. So there's a couple different things that we do to support our members. A big one is our biweekly calls.
Right.
So every other Friday afternoon, we get together for a call. It's about depending on what's going on, but typically it's about 30 minutes or so. And it's really just, we get an update from Capitol Health Consulting on what's going on legislatively. So it's a legislative update, but it's also an opportunity to talk about, what's going on, really ongoing issues, new issues, and just kind of get together. Another thing, in addition to the regional meetings, which has been a great initiative, a new thing that our membership committee, and our membership committee has done a great job this year putting together initiatives to try to grow our membership, but also to add value to have membership in the association in addition to all these other things. But they started an administrators club.
Right.
And this is something, again, it was a new initiative. The plan is to do it quarterly. We just had our first one last month. But what it is it's an opportunity, a little bit more of an open forum type of thing as compared to what our biweekly update calls, but where everybody, around lunchtime, for an hour or so, get together on a Zoom call. We've kind of come up with a topic, but it's kind of open-ended. It's an opportunity for everybody just to talk, network and really, share some ideas about, how to address some of the challenges we're having. And so we had our first one last month. I thought it was very successful. It was well attended. We've had good feedback of it, and we'll be planning the next one. Probably December can be tough because of the holidays, but December or January will be the next one, and we're really looking forward to that.
Highly attended too. I mean, it seems to me like virtually every member is on that call for at least a few minutes to find out what's going on. And lastly, New York is not alone in this country. They banded together for various initiatives over here during the pandemics. The tri-state area, for example, came together and worked on things. So New York, Virginia, Massachusetts, Pennsylvania, and Texas got together in June to do the multi-state in cooperation with the ASC Podcast. Planning for the multi-state is June 2024, already in place, and we're looking to double the number of states. So thank you so much for being one of the supporters for that. And that is a free 16 credit hours, 2-day virtual conference that's available to anybody that's a member. So if you're a CASC or CAPE certified and you're a member of the New York State Association, you can really get all of your credits you need for your 3-year cycle through the New York State Association, through the various things that they offer.
Absolutely. And then the other important thing is new initiatives that we're working on, like in speaking with those other states and getting involved. Like a real initiative this year is going to be trying to get cardiac into the surgery centers. And, we're looking towards Texas because they actually have it in place. And
Pennsylvania too.
they've actually opened up 2 of the surgery centers down there to speak with us about what we need to do to go forward. Also, California has also been very generous in giving us information as to how we should start the process as they're going through it themselves.
Well, I think it's important as our organization, as the state associations continue or try to grow through this difficult time, is to share resources as much as possible.
Absolutely. And John, thanks for bringing up, that multi-state conference. We appreciate your organization putting that together and the podcast putting that together and your support of our organization and giving another opportunity, like I mentioned, other opportunities for our members to some value added things with the membership. And also I'd be remiss if I didn't mention everything you do with the podcast. And congratulations on the 200th episode. I listened to that on my drive up yesterday. On my drive up yesterday. It was a 2.5 hour drive, it was perfect.
Were you able to get through it? I can't remember.
I was. It was great. And again, I enjoy listening to it, and I appreciate you taking the time to have us on the podcast, and we're happy to be on it. I think this is probably our 4th or 5th year
easily
time, being on the podcast.
I think you've been on every year actually since we started, because you're kind of, and that just does bring up an important point. We know that you are so busy in the centers that you can't get everybody out. Maybe we got people who have 4 people here. We got 15 people from Ambulatory Surgery Centers, but we got people that have 4 people. I don't know how the average surgery center can do that. They're lucky if they can get one out. So one of the things that we are committed in the state association is not only offering opportunities here for the leadership, but to get it down to the people that really need that work. And that's where the multi-state comes in. That's where these regional meetings come in. The regional meetings are all after hours. So if you can drag, maybe give the guy or gal a couple hours off, on another day and bring them out to this so that they can listen to an hour of whatever we have. We talked about maybe doing some life safety, talking, a couple different topics that we talked about in the board meeting, and that we work on in the education committee and make sure we're offering it throughout the state. So
absolutely.
And just to add, your podcast actually, the unique thing about that compared to other groups that have tried to do it also is that you actually address the real issues that we're facing in the centers, because you're in the centers, your people are in the centers, and you find out what the issues are. You really keep focusing on it. So thank you for doing that, because it allows other people the opportunity to start to learn.
I appreciate it. Thank you. Thank you so much for joining us. And I know I got another interview coming up soon, and you got to kick off the meeting in a few hours or an hour.
Thank you, John.
Thank you very much. Take care.
Sure. Thanks.
Then we have an interview with Mark Beckman. He's a lawyer that was speaking about the legal side of anesthesia services, especially in light of all of the problems that we're having with anesthesia right now, the anesthesia crisis, which was a major focus of this conference.
I'm here at the New York State Association of Ambulatory Surgery Centers annual conference in Albany, New York, and I have Mark Beckman here with CCB Law. I have a long history with CCB Law, and my dear friend Bruce Smith, who I've known for many, many years, could not make it because I understand he's got a big birthday right now. So he assigned you to do this.
He did. I think he's on a camel somewhere in the Sahara Desert.
Well, that sounds like a lot of fun if you like deserts.
If that's what you're into.
So when I talked to Bruce, and you and I hadn't actually talked directly, but when I talked to Bruce, I said, give me a fun title for probably a boring, a topic. It's not going to be boring, but it could.
The legal world is fascinating.
That's right. So he came up with the title, No Gas, No Cash, Adventures in ASC Anesthesia. And what we're talking about now, we've been talking during this entire conference so far, and it's only half a day gone, about what we're referring to now as an anesthesia crisis. We know that anesthesiologists are short supply. Many of our surgery centers, maybe I'm assuming many of our listeners are getting notices, that they're no longer going to have the support of the anesthesia group they had before. So looking at alternatives or looking at opportunities out there to change their existing models, and sometimes they're being forced to do that. So that's where you come in.
And I wish we had answers.
Yeah, I guess that's one thing we should state.
We're fielding more questions than having answers at this point.
Yeah.
And I think it's a testament also to how fast the world of healthcare can change. Right? It wasn't that long ago where the roles were reversed.
Yeah, right. Exactly.
And also, different specialties are feeling it differently.
Right.
Right. And so some of the models that would work for orthopedics may not work for cataract surgery centers.
Yeah. Because the reimbursement for the anesthesiologist there.
Well, and it varied. So, and the case mix is so much different, for orthopedics than it would be for, let's say, a center that does cataracts all day long, right? And so the variance is very different. So you might use a different model to address that situation.
Yeah. So many of our listeners really don't understand the financial model behind anesthesia. And for that matter, they might not have ever been involved in negotiation of the anesthesia contract. And that it never becomes an issue until the day, right? Until it is. So they didn't spend a lot of time reading those contracts, finding out how long they would have to find another anesthesia provider. So that's why I think we've approached this from the anesthesia provider standpoint. Tell us what's going on with their side. From the administrator standpoint, what happens when you get the notice? And now with you, we're dealing with it really from the legal side.
Well, I think it's a great point, though, that you make, is that so many of these contracts were entered into years ago, put in a drawer, and nobody ever looks at it. And when the market is changing, it's not a terrible idea to pull out some of those contracts so you're aware, and it can at least act proactively if you need to. If there's an opportunity for planning, you know what it is. Unfortunately, in our business, we are often dealing with addressing something that's already happened.
Yeah.
And
it's too
sometimes
late.
there's nothing you can do about it.
Right.
And so if you can at least take action in advance and maybe address some of these contracts in a way that gives you more protection for the roller coaster that we're all on, that might not be a terrible idea.
So let's start with that, is because even those organizations that are not going through an anesthesia crisis yet, there's a good chance that they will in the future. When they're looking at that contract, what should they be looking at? Even if they recognize, just because they know they can't change it doesn't mean they don't look at it and understand what the risks are. What are they looking for?
Well, one of the things I know is a common misperception, for example, is, I have a 5-year contract.
Yeah.
Well, what does the termination provision say?
Yeah.
Right? Is the termination provision say that any party can get out of it on much less notice, 60 days, 90 days, 120 days? That's the real term of your agreement.
Yeah.
Right? The days of a no-cut contract, if you would, I think are over.
Yeah.
And then there's also some of the more objective versus subjective provisions that you might want to take a look at. So, as an example, do you have other opportunities to ensure that the anesthesia services are going to be acceptable to your surgeons? Is there a clause, for example, that requires the anesthesiologist to work harmoniously, and that's a very subjective term, harmoniously with the surgeons, and what happens if they don't? What's your recourse? Disruptive physicians, that's a real issue in healthcare, and you want to be prepared for the what ifs in that respect. Even if it's not a breach of the agreement, do you have some rights?
Yeah. Well, and you bring up an interesting point also from that standpoint, is that what happens when the doctors disagree about the care of a particular patient, or they feel like the anesthesiologists are being too strict about the patients that they want to be seen at the surgery center. Those are things that should be dealt with in that contract.
That's a big issue, and also depends on who's the supervising physician. Sometimes the surgeon has taken on that responsibility. In that instance, they obviously need to ensure that they have the last say, because they're ultimately the responsible. With a CRNA, for example.
Yeah, right. Yeah, when they're not, when you don't have
Which is very common, right?
So talk a little bit about talk a lot about some of the other models that are out there. The traditional model is that you don't even hire. You have a contract with an anesthesia group, comes in, they provide anesthesiologists, and you don't. I mean, that's kind of it. You've appointed a chief of anesthesia, and everything else is taken care of. But that world is changing very dramatically.
Like in a traditional hospital, right?
Yeah.
There would be the surgeon comes in, he does his thing. The anesthesiologist, she comes in and she does her thing. They really don't have a relationship, a contractual relationship with each other. They're just members of the same medical staff,
and they're both billing independently.
Correct.
And there's no financial relationship.
And so it wasn't that long ago that in some specialties, for sure, the surgeons were wanting to own a anesthesia practice right, separately, or they were managing that practice for a fair market value fee. Now, as you know, the tide has turned a little bit. And so one of the things that I would suggest is, can you make your anesthesiologist your partner, right? And feel like your partner in some way, so that whichever way it ends up going in the next 5 years, you're in it together.
Yeah.
But some of the models would include fixed subsidy. They would include income guarantees.
Right.
They would case guarantees, recruitment assistance, all of which have to be properly documented and evaluated for fair market value because of anti-kickback statute concerns in particular. But they can all be done if done correctly.
Yeah, and having a lawyer involved as a trusted advisor throughout this whole process is important.
Always. You would never hear me say otherwise.
No, I know.
But honestly, we would rather be in a position where we're your partner also.
Yeah,
right.
Right.
And that we may not have the answers, but we can help walk you through the issues, and we can talk about them together. Too often this happened. Now what do I do?
That's right.
I say, well, it's too late to do it.
Yeah.
Yeah. So there's always something that can be done, but you'd rather be proactive than reactive always.
So there's a lot of conversation right now about the movement away from anesthesiologists, since they're so hard to find, and then movement towards CRNAs, which, by the way, they're hard to find too. But many centers have relied on anesthesiologists over the years and have had to consider changing that structure, and perhaps not even ever having an anesthesiologist involved. Maybe like in the state of New York, where we're talking right now, the CRNA has to work under the auspices of a physician, be it an anesthesiologist or the physician, the operating room physician.
Right. Every state's going to be different on that issue.
Right.
Now in New York, technically, to my knowledge, there isn't a ratio that's specific, but the insurers, are changing those ratios. So where it might have been 1 in 4 for certain insurers, maybe now it's 1 in 3. Right. And so that's going to also dictate the market.
Right. And I also should mention here, whenever you're making any changes to the anesthesia services that you're offering, you need to make sure that your malpractice carrier is well aware of that too. It's one of those things that they the last thing they think about, and then, you never want to run into a situation.
It's interesting you say that, because I fielded a question at the conference today about that, and it's not self-effectuating, right? It's your responsibility to tell them, typically under your contract. They're only going to know what you tell them, and then they will hold what you don't tell them against you.
That's right. Well, this happened back in the day when we were doing LASIK surgery in surgery centers. People just said, well, it's just a natural place to start doing it. Let's just start doing it. And then they found out that, they never notified the insurance company, and they weren't covered from a malpractice standpoint for that. Right. You want to avoid those situations. So where do you think we're heading? If you're going to notice that the anesthesia group is pulling out, and they say we're going to, whatever that term says, whatever that contract says, it doesn't matter whether it's 30, 60, 90 days. 90 days might still not be enough. What do they need to be doing, to protect themselves? I mean, one thing obviously is make sure they look at that contract first. But
again, if you can lock them up, right? And this is where you'd rather negotiate while you're still friendly than not, or they've gotten a better opportunity somewhere and it's too late. So maybe lengthen those terms, lengthen those notice provisions, and sweeten the pot a little bit. Again, talk about expansion, talk about recruitment assistance. If you're seen as their partner, maybe you'll gain some goodwill that way. The other thing, one of the things that I don't know what the future is going to hold, because of what's going on at the federal level with the FTC. We are seeing some heightened enforcement against some national anesthesia company providers, maybe whether they're in private equity backed or otherwise, where if they've been asserting their market leverage to the point where insurers get upset, the first place they run is to the government and cry antitrust. And we are seeing, there was a case just a couple of weeks ago reported in the New York Times in Texas about the FTC bringing an actual lawsuit now against, I think it's U.S. Anesthesia Partners, and naming their private equity backed transaction partners. So even though the case is in Texas, the private equity company was in New York. And so we're going to see some news about that as well. And I think I was at a conference last week with a lot of DOJ and OIG people telling me to expect more of the same.
Yeah. So
that might change the market again.
Right. What are you seeing with regard to ASCs and the owners of the ASCs, hiring ASCs or CRNAs directly? What is the complexity of that? How does that work? Is that an option? Is it a viable option? What risk might they have?
It's definitely a viable option, but the other thing that you're seeing at the same time is restrictive covenants may be going away, and so where you before might have been able to take more advantage of that, they're going to play the market just like anybody else, and you're not going to have the ability to as easily lock them up. Employment is just that. It's for as long as I want it to be. And if I don't want to work for you, even if I have a contract, no court is going to make me work for you.
Yeah,
right.
yeah. And the price is going up, and we know
going up.
Yeah,
absolutely.
and we saw it. One of our centers, they just finished negotiating a contract, hadn't signed it yet, and the CRNAs came back and said, "By the way, we're leaving." And because we just offered $50,000 more a year, what are they going to do? Well, come up with $50,000 a year and renegotiate the contract you already negotiated.
So the only potential recourse in some of these areas would be if you have a longer term contract, whoever hired them might be in tortious interference with your contract.
Yeah, good point. The concern I also have is that it's easy to get angry at what's happening here, and that's just not going to solve the problem. We've got to remain partners. Try to build up that relationship beforehand. Make sure that you're not ending up calling a lawyer next for that. But have that lawyer first. Right. Make sure you have a good contract in place.
And again, we pride ourselves on being the type of lawyers that we would help you with your business decisions before they become legal decisions.
Right. That's a very good point. Yeah, always look at those. We've been talking a lot about in our company and in the podcast about certain agreements. This is a little bit off topic right now, but the medical staff bylaws, the operating agreements, which I'm sure you work on in your career. Those are documents. I'm often pulling them out for new clients, and I say, my God, this hasn't even been looked at in 20 years, and you're not doing anything close to what it says here. So be very careful.
Absolutely, and they'll be held against the center as well.
Right. And it's tied in
when you're trying to enforce, some of those medical staff expectations.
Yeah, exactly. I think the medical staff bylaws in particular, and those are the ones I find that are often just completely forgotten. They throw it in a drawer and they don't look at it for 20 years. The operating agreement, because it involves the relationship between the partners, that's a little bit more current. But the medical staff bylaws, which totally affect what's going on with the anesthesia group.
We only did them because we're obligated to do them, not because we care what they say necessarily. And so we just got something off the shelf, which is not helpful, right?
And they might not have even gone through a lawyer. Frankly, often, I find that so.
Or even more importantly, they're not customized to your situation.
Yeah. I've seen that a lot.
Nobody's thinking about our situation, or we use the term living document all the time. So these governing documents should be seen as something that should be reviewed regularly to make sure that they still meet your needs.
And here's my recommendation. What we're doing within Ambulatory Healthcare Strategies, we're encouraging our listeners to do this also, is include in the annual things you're looking at. On an annual, you have to look at your policies and procedures. You have to, look at your quality improvement program, risk management, et cetera. Including that, a look back on your medical staff bylaws and your operating agreement. Make sure you're totally in compliance.
I would agree with that. Yeah,
and work with your lawyer.
Yeah, it may not be a compliance thing, but it goes to what problems are you trying to anticipate to avoid.
Right. Thank you so much, Mark. I really appreciate your time. This has been fun.
It's been my pleasure. Thank you for having me.
And next we'll listen to Dr. George Kofinas, who talked about the importance of membership in the state association as an owner of an ambulatory surgery center.
We're here at the 2023 Annual New York State Association Conference, and I'm here with Dr. George Kofinas. Dr. Kofinas and I go way back. We helped him with the surgery center that he has in Manhattan Reproductive. Dr. Kofinas, tell us a little bit about yourself and about your center and your practice.
I am an obstetrician gynecologist with subspecialty in reproductive endocrinology and infertility, and of course reproductive surgery. And we built that center in order to be able to do the procedures that we do for the enhancement or restoration of fertility in a center that it is built specifically for that purpose.
And also have Gabe Figueroa, who is the administrator for that center here. Gabe and I also go back. We're very dear friends. I love visiting your center. It's on the 21st floor right on Wall Street. It's a pretty nice view down there. Traffic problem? I won't go into that. So
we don't drive in Manhattan.
I know. Unfortunately, I do. Stupidly.
No, it's a great place. I think we have the highest ORs in maybe New York, right?
I think you do.
Yeah. So it is a unique place. We've tried to create an environment that fosters a sort of calming and sensing place for the patients.
Right.
Obviously, our patients are slightly different than a lot of other specialties. There's a lot of emotion and so we try to
high motivation to be there.
Highly motivated, but also they're dealing with things that they don't always understand 100%.
Yeah.
So we try to create an environment that's soothing and calming for them.
So New York is not unusual as a state that requires a certificate of need. You applied for the CON a number of years ago, got it from Manhattan Reproductive. You're actually building another surgery center. The two of you are working on a project that we're involved in also out in Staten Island, which is coming very close. That's going to be opening. I haven't talked to Jenna recently to find out exactly when that's going to be.
We're hoping that we'll be finished by the end of the year, targeting to start doing cases in January of 24.
Gotcha. So the first question I have is, are you crazy to get a CON in the state of New York? What led you to this, and talk about the challenges you have and the challenges of maintaining it.
Yes and no. Yes, because the process is unbelievably difficult.
Yeah.
And no, because after we got the CON and we built the center, our life has changed 180 degrees, because now we have the luxury of operating our patients and performing our procedures in an environment which was built specifically for what we do. Right. And this is a huge advantage, number one, for our patients, and number two, for us. The flow of the patients into our center is uninterrupted, and the benefits to the patients are enormous because they don't have to go to the hospital. They don't have to be hospitalized. Mm-hmm. They are discharged the same day with minimal blood loss.
Right.
And, of course, great outcomes in terms of infection control and other complications.
So I think the control factor is extremely important here compared to where you were before and what you had to do before. You control the environment, you control the quality, you control the equipment that you purchase.
That is 100% correct. And I think this is the most important factor that contributes to the happiness of the patients and us. And I'll give you a few examples. If we have if we need an instrument, a new instrument, or a new piece of equipment, our decision process, the decision-making process lasts a few seconds. We decide we need it, we buy it next day. We don't have to go through committee after committee after committee, and at the time that the decision is made, the instrument or the piece of equipment is obsolete.
Yeah. And in today's environment, you can literally get it the next day.
We can get it literally the next day. Another advantage we have is that we control the quality of the equipment that we buy and instrumentation, and also we control the redundancy of the equipment.
Yeah.
And what I mean is equipment breaks.
Yeah.
And equipment can break during the procedure.
Yeah.
And you have to have every single piece of the equipment that we use duplicated.
Yeah.
Standby, ready to be used in a few minutes.
Yeah.
So that is another advantage we have, which we did not have in the hospital. Of course, there were equipment to be replaced, but it would take 20, 30 minutes.
Yeah.
And you have the patient under anesthesia for 30 minutes waiting for a piece of equipment to be moved from another operating room, which is used now, to bring it in the other. Those are all tremendous advantages. Another advantage is we choose the instruments we will buy, not the hospital, not somebody that does not understand what exactly we need, how exactly we use it. So this is another tremendous advantage. We have control over the cleanliness and everything else in the unit, and that creates an environment which makes the employees happy, the staff, the nurses, everybody. And of course, that reflects eventually on the care that the patient gets, and the patients are raving about it.
Yeah. So, Dr. Kafinas, you alluded to staffing. Yes. And I think another area of control, Gabe, why don't you talk about the importance of being able to control who you hire, the quality of the people, the training, which, again, you don't get when you're working at a hospital.
Yeah, we've taken a different approach, I think, than traditional, given the fact that we've been faced with a ton of challenges in terms of finding experienced staff. And so we have tried to focus on what we sort of call our core attributes of an individual, which are things that they possess that you can't teach, right? Growing and training our own people sort of from a fundamental level of how the perioperative environment works in an ASC has proven to be successful for us, because it's very difficult to go out there and find a nurse who has circulating experience in the ASC. There's just not that many, right?
Yeah. And there's also a perception sometimes in the hospital environment, I'm going to go to the surgery center because it's going to be easier, which is what?
Yeah, it's not easier.
It's not easier, right.
That's something we struggle with. We're still struggling with it. Understanding the appropriate staffing levels that you need to give staff predictability in their day. Yeah. That's a constant challenge, right? Surgery is not always predictable. You schedule a case for 2 hours, it can take longer than that. So that impacts everyone. So we've tried to focus on those things, and that's across the board. I know we kind of try to hyper focus on nursing, but we kind of take this approach with everyone. I just met with an anesthesiologist the other day, and it was the same approach with even the doctors.
Right.
So that's yielded us some positive results. But I still think, obviously, if you can find the experience, that is also very important, because even the method that we're taking gets you through a certain point, right? Yeah. But you can't buy experience. That just takes time. And so when you get into the situations where you have a code or you have a patient deteriorating in the OR, you see that experience kind of rise to the top. So it's tough, It's a little easier for us. We're a single specialty, so the learning curve is a little not as steep. You're not jumping from ortho to urology to GYN. We do the same stuff every day.
It's a relatively small population of procedures.
It's a small, So they get a lot of repetition in terms of the types of cases we do.
So once you hire them, you of course need to make sure they stay up, especially when we're talking leaders, people like yourself and your staff. And Sarah, your director of nursing, is in the room here. I know she's staying as far away from the microphone as she can possibly get. But it doesn't stop with hiring and training in-house. You constantly have to go somewhere else. You have to have information about the regulatory environment. And of course, Ambulatory Healthcare Strategies helps your company. We're very proud to be part of it. But it's more than that. You need to have the support of the other surgery centers in the state. So how do we do that? State association.
I think we need to come together more as a community. I think traditionally, this very well, having been here in the state for so long, we were very siloed. Surgery centers were almost islands unto themselves, where we were not a community at all. Reaching out to each other, not just for, hey, can I borrow this piece of equipment, but also asking for best practices, or hey, do you have an idea on a quality improvement study, or I'm facing this problem with whatever it is. We need to use each other as a resource and come together. I think hopefully the association is making a push to break down those silos so that we can come together. I mean, we're, I think, 49th per capita in the country in terms of surgery centers. There's plenty of business for everyone. We're not competition. And so Case in point, Staten Island, which you brought up earlier, has a population of 700,000 people with no multi-specialty center. Yeah. Ours will be the first. Yeah. I mean, we need to extend our hands out to each other and come together as a community.
So again, the membership in the state association helps you to have those resources available, but it needs to come from the top, Dr. Capinas. You need to be supportive of the organization and make sure that your leaders in your organization are part of it. Talk a little bit about how you support. Gabe has to be away from the center. Well, of course, you're away from the center right now, so no business is being transacted while you're gone. But when Gabe's not there, you have a leadership gap. But how important is it to be here?
It is extremely important. Mm-hmm. First of all, I'm in the ASC business new because we only opened 4 years ago. I don't know many other owners of ASCs, and especially other owners that they are practicing surgeons,
right.
like I am. But I think it's very important. We should exchange ideas. Mm-hmm. We should exchange ideas into practically everything, best practices, best equipment, best instrumentation, ways to save money in doing the operations without compromising quality. Our motto and our goal is better quality, better outcomes with less expenses. Mm-hmm. Basically, we try to eliminate waste, which plagues the hospitals and some ASCs. We have developed certain systems where we pick up the best instrumentation possible with the lowest cost possible. And I will give you one small example. Mm-hmm. Trocars. Yeah. They use disposable trocars, which is $350 each. I pay $800, and I buy titanium trocars that they can be used in 2,000 or 3,000 cases. Now, if you break down the cost is pennies compared to $350. If you use 4 trocars, you added already $1,500 on the cost of the procedure. And that's unsustainable. Then you become a hospital.
Yeah.
We don't want to do that. We want to really use the best instruments at the least cost, which helps us advance and add more services and better services. And of course, it helps the bottom line.
Well, and from an environmental standpoint, there's less.
An environmental standpoint, we do not pollute the environment because all this plastic has to be disposed somewhere because it's not reusable and it's not repurposed. Whereas with the sterilization of the reusable equipment, especially if it is high quality, like titanium or stainless steel, special for surgery, we do not pollute.
You and I are about to go and kick off the meeting with a panel discussion of the future of the ASC industry. And when we were preparing for it, you were talking very strongly about your opinions about, the challenges that you face as a surgeon in the highly regulatory environment that we have here. Can you talk a little bit about what you're going to say to our audience and how important it is to be actively involved with talking to the Department of Health, talking to the regulators, talking to our legislators about this topic?
Well, basically, regulation is a problem that affects everybody, affects the ambulatory surgery centers, affects the hospitals, affects independent practitioners in any capacity, especially if they have an office-based surgery. Now, sometimes we feel, all of us, and everywhere you hear complaints that it's too much regulation for everything, that not only it does not add to delivery of better health care, but it subtracts because it eats up resources that can be used to advance the quality of the care for the patients. And of course, it is a burden because it distracts everybody and make them lose focus from what their primary job is, delivering excellent health care to the patient.
Yeah, and we need to make it clear that we're not arguing that we need regulations. The question is, do we need some of these regulations that have been created by people who don't understand the healthcare industry and are there, to deal with one issue that might have happened once in 100,000 cases?
This is a major problem.
Yeah.
And I don't know where the problem is. Is it the problem that the people that really understand healthcare, they don't have the time and they don't get involved.
We don't get involved. You're right. I mean, yeah.
Either because they don't want to get involved or because they are not asked to be involved. I don't have an answer to this, but I think a lot can be done when cool heads get together and really dissect the problems, the potential problems, and how to form regulations that will make sense and they will really advance the healthcare environment.
I want to thank both of you for joining us here, and Sarah in the background here taking pictures of us as we're doing this. It has been a great opportunity to speak to an actually, it's very rare that we actually have somebody on the show that actually owns a surgery center. So I think that's something we need to do a little more frequently here because we need your voices and we need to know that we're here to support you.
Thank you very much for having us.
Thanks, John.
Thank you. As a leader in the ambulatory surgery industry, you already know that the ASC Podcast with John Goehle is your ultimate free resource for staying updated with the latest news and information while ensuring your organization maintains regulatory and accreditation compliance. But did you know that we have 2 membership programs on our partner website, ASC-Central, that can take your organization to the next level? For just $25 a month, our patron program will unlock a host of amazing benefits. Enjoy regular Zoom meetings with our hosts and special guests, access to recorded conferences like our credentialing seminar, Conditions for Coverage Conference, Medical Director Conference, and our most recent 2-day multi-state conference. The patron program also offers a comprehensive database of policies, forms, drills, example minutes, and other invaluable resources to optimize your center's operations. For those centers that want even more, our new ASC-Central Premium Access Plan offers a variety of online services to its members. The benefits include access to a wide range of services, including all of the benefits of the patron program, unlimited access to our popular bootcamps, the ASC industry's most comprehensive training for ASC leadership. Members can attend any number of the ASC Administrator Bootcamps and ASC Director of Nursing Bootcamps and can listen to the recordings throughout their membership. It also includes unlimited access to the industry's most comprehensive infection control training, designed for infection control coordinators and those that wish to take the Certified Ambulatory Surgery Center Infection Preventionist exam. And the program also includes up to 5 hours of private consultations by Zoom. For more information about these 2 programs, visit our website at ascpodcast.com or click on the links in the show notes.
And next we talk to Dr. Joseph Puma about new opportunities for cardiology procedures.
We're here at the New York State Association meeting in October of 2023 in Albany, New York. I'm here with Dr. Joseph Puma, who is a cardiac doctor. Introduce yourself, because we haven't had a lot of time to talk about your background.
Hi, John. Thanks for inviting me. My name is Dr. Joseph Puma. I'm the founder and president of Sorin Medical, which is the largest private interventional cardiology practice in New York City, and founder of an outpatient facility in Lower Manhattan on Wall Street and South Street.
And it's currently an office-based surgery practice, correct?
Yes, it's an office-based surgery practice. We have applied for our CON, are in the process, and also have founded the New York Cardiovascular Ambulatory Surgical Society,
right?
As outpatient interventional cardiac procedures are now taking hold around the country, but have yet to been approved in New York State.
Yeah, and that's the point that we want to lead with here is that for I'm not sure all of our listeners from New York State know this, but cardiology is now reimbursed, or some of the procedures are being reimbursed by Medicare. This is not new. It started a couple of years ago. But if you are in New York State, what is your opportunity to do outpatient cardiology procedures in an ambulatory surgery setting?
Well, the answer to that's pretty easy. It's zero.
Right. Yeah.
In states without certificate of need, such as Florida, Texas, Louisiana, Arizona, procedures, outpatient coronary stent procedures, implantations of pacemakers, battery changes, things that are
Yeah.
At this point in time, safe, routine, and often occurring,
Right.
especially as the population ages, have been done in outpatient facilities now for several years. The only state that has a certificate of need that has approved it has been Pennsylvania, and that was, I believe, last July and just went into effect this past July. So New York State is a little bit behind from a regulatory standpoint, and unfortunately, patients have to still go to hospitals, which, as we all know, are not quite as efficient or way higher cost, and the patient experience isn't quite as good.
Right, especially post-COVID. I mean, there is a huge role for hospitals, but it's not the place. I mean, it used to be the place where everything was done, healthcare, but that's really not where we're heading anymore, nor can it be where we're heading.
Yeah, I agree, and I think that COVID, the tragedy of COVID for so many of us, for the entire world, was obviously unfortunate. But what COVID did was it highlighted, it really brought to the surface many of the holes in the healthcare system, and I think they were exposed. They were there already,
correct.
But one of them was the hospital's ability or suitability, maybe is the right word.
That's a good point.
To be managing all of these elective, safe, outpatient procedures in an inpatient setting.
Yeah, and we saw also, for those that are not aware, many of the hospitals in New York, like I live in Rochester, New York, those hospitals are almost 100% occupied at any given time. It doesn't matter the time of year. It's just that that's the way it is, that the hospitals have been shut down to such a degree that that they're operating at what our regulators think is an efficient level of 100% at all time, but which means no leeway for a crisis like the pandemic. That's why we had to open up. That's why we had to, park a ship in the middle of, the harbor in order to take care of patients during the pandemic. So it's not even a matter of this is the right place to do surgery because we can do it safely. We have no choice. We just don't have the capacity anymore in the hospitals to continue doing the same thing that we've been doing for a long time.
Yeah, those are great points. If the goal is access to care, quality care, and lower cost care, right? That's the triumvirate of high value care.
Yeah.
Then you have to ask yourself the question, is the cost structure of large institutions, of health systems, the appropriate place to achieve that?
Yeah.
We now have 40 years of history in ambulatory surgical centers,
right.
Having started with simple procedures, colonoscopies,
right.
Some minor orthopedic procedures, ophthalmologic procedures, and now, after 40 years, routinely, all over the country, patients have joints replaced, knees and hips. They have their colonoscopies done, and it's very safely in outpatient facilities. They have all types of eye procedures, cosmetic procedures. So the issue of safety, I believe, has been answered.
Right.
Even on the cardiac side, the national societies have position papers, which have been very clear that outpatient cardiac procedures, coronary stent procedures, and diagnostic catheterizations are as safe as if they were done in a hospital setting.
So what do you think the roadblock is? I mean, you're really intimately involved in this and working with your association to try to get the change. What are the roadblocks to being able to make those changes, to get cardiology allowed in the surgery center setting?
That's a great question. Well, cardiology in general, it's always interesting. There's a certain amount of fear when it comes to cardiac procedures.
Right.
Everyone always, thinks of the, what they see in the movies, the patient that has a severe heart attack and their heart goes out of rhythm and they're getting shocked. So I think that there's a misunderstanding of the safety profile right now. Secondary, from a regulatory standpoint, I think the Department of Health and the state have a lot on their plate, quite
Very
frankly.
True.
And
they are still recovering from COVID and the ramifications of it.
Yeah, and so getting caught up with where things ought to be. I think third, it's a policy issue as well.
Yeah.
I'm pretty sure the hospitals don't want to give it up.
Right. It's profitable.
Cardiology has always been profitable.
Yeah.
and often the most profitable service line as hospitals talk about it. And so I don't think that they want to give it up. I think the other thing that's interesting now is that since the passage of the Affordable Care Act and the rise, if you will, of the health systems, many private practice doctors have essentially gone out of practice.
Yeah.
And either are working for hospital systems now, so they're employed, so they no longer have a dog in the race, so to speak.
Yeah. I think, speaking as somebody, I've never done cardiology in any of my centers. I've been in the industry for 33 years, and when it came on the horizon, I was just telling you before we started the recording that, we don't have any experience in it, so it's scary right now. And you're used to it. So, so talk to our audience about how we get past that scare, that fear that they have that you referred to. But, it's not just the people out there, it's our own people. How do we convince them that this is something that can be done safely, that you're not going to have to, worry about transferring a quarter of your patients to the hospital after this procedure?
Well, like everything else, let's look at cardiology in the United States right now. Most cath labs in the United States, about half of the patients came in through the emergency room with a minor or major heart attack. Those patients are not going to be done in an outpatient center. Of the remaining 50%, about 80% of those would fit the profile. Normal kidney function, heart muscle function, in good shape, no evidence or no signs or symptoms of congestive heart failure. Those patients are perfect for an outpatient procedure. 20% of those have high acuity. They either have very complex heart anatomy that you may know before or at the time of the diagnostic cath, and you don't want to do that in an outpatient facility, or they have kidney dysfunction, they have bad COPD, breathing abnormalities, or liver disease. And so a lot of it has to do with patient selection. Second, I think where the transition has to be. Most multi-specialty ASCs are essentially like a hospital OR. You have general skilled nursing staff, general skilled scrub techs, and you have general operational equipment that you use. Cardiology is different. Special radiology equipment. The operating room actually has a big X-ray tube in it. It's not just an operating bed. And the technicians have to be specially trained in cardiac physiology and hemodynamics. But they're
out there,
it's not.
They're already working somewhere else.
That's exactly right. So it's not like we got to go to Mars to find these people.
Right.
And then, like anything else, like we've done for years in ambulatory surgical centers, you get experienced people who have managed. There are nurse managers out there that are outstanding, that have managed cardiac cath labs in hospitals all over this country, that have wealth of experience. So there is fear, and that was the first thing I said. I think that there's a fear there. But I think that we can get over that. Let's remember, the first orthopedic procedure done in an ambulatory surgical center wasn't a hip replacement.
Yeah, that's right.
All right, let's be clear about that.
That's very clear. That's a very good point. Yeah.
It was it was an incision and a needle aspiration of a knee joint.
Right.
And look how we've progressed.
I think that's exactly the point. You're right. I mean, we look at those two procedures very differently because one is that heart, and you don't want to fool around. It's like when we start doing brain surgery, which we will be doing at some point. I'm sure we're going to have that same fear, but we've got to get over it because this is the right place to do these procedures. This is, you're going to have a much better outcome, much more. You said it right from the very beginning. Access is a real problem that we have. And having access to high quality, low cost care in an ambulatory surgery center is our mantra every day.
Yeah, I would bring up one other point, one other interesting point that I'm not sure people completely understand. First of all, anytime you do any procedures, there's always a risk of a complication.
Yeah.
And hospitals like ambulatory surgical centers have complications, and we all work very, very hard to minimize them. But in ambulatory surgical centers, the most common complications are usually anesthesia related.
Yeah, that's very true. Yeah.
In the cath lab, there's no anesthesia.
Right.
It's actually more like an office-based surgery where there's what we call conscious sedation or moderate sedation. Patients just getting a little Versed or fentanyl intravenous just to relax them and sedate them. but it's not anesthesia, and that's usually administered by the nurse without an anesthesiologist present.
Under the supervision of the physician.
Under the supervision of the performing physician. So interestingly, I might say that the complication rate theoretically might actually be lower. And it might be a safer procedure than bariatric surgery, which is taking place now in ambulatory surgical centers, hip replacements where they're staying overnight, there's risks of blood clots, things like that.
Well, and the other situation we've been talking about quite a bit in the state association meeting here is the anesthesia problem that we have. So what you've just described is a growth opportunity for a surgery center that's not going to compound your existing anesthesia problem, as long as you have good, nurses, obviously, that can do conscious sedation.
Absolutely. And absolutely. As we all know, anesthesia is going to become a crisis.
Right. Very soon, if it isn't already.
In the ambulatory surgical center. And a lot of that has to do with a limited supply, a higher demand for anesthesia and CRNAs, and a reimbursement problem right now. So I agree with you. I see growth in ambulatory surgical centers. If you look back at it historically now and you kind of just plot out the arch, the next 5 years, ambulatory surgical centers are going to become cardiovascular centers. Those who 99% of the dollars spent in cardiology is spent in the hospital. That's usually the biggest dollar amount spent in healthcare on any service line or disease state. It just can't continue.
Right.
For so many reasons. Every state, every city, their healthcare budget is strained. It cannot sustain the growth. And so I think it's going to just take a little innovation and a lot of work with societies like this that are getting the message out and that are doing the regulatory work and working with the your group that actually manages ASCs, and you'll have that institutional knowledge to help facilities and practitioners and patients do it safely, increased access, and lower cost.
So if you were to predict where we're going to be in a year, are we going to be closer? Are we going to be, I'm probably asking you a very difficult question there, but what is going to be the time frame for getting this based upon what you've been working on?
I think this is going to be like one of those, like watching dominoes fall. You see that one domino getting ready to go, but it does, it's kind of shaky.
Yeah.
And so I don't know if that shakiness is going to be 1 year or 2 years.
Yeah.
My feeling is if New York State led the way, they would all start flying down.
Right.
I think the pivotal moment, though, may turn out being Pennsylvania.
Yeah, very good point.
Because that was a regulatory issue.
Yeah.
They had to pass a law. The governor had to sign it.
Yeah.
And now that has occurred,
yeah,
it would be very difficult for contiguous states,
right,
to not move ahead. Because let's face it, if I needed a coronary stent and I lived close to Philadelphia, I might just go to an outstanding interventionalist in Philadelphia in an outpatient way.
Right.
I'd be there in the morning. I'd be home for supper.
And if the insurance company, they'd be absolutely stupid not to pay for that travel, given the savings that they're likely to have as a result of going into an outpatient setting compared to the hospital.
The reality is most insurance companies that my group works with at a high level right now, they are actively trying to motivate their the people they care for to receive any care that can be done in an ASC to be done in an ASC.
Yeah.
And the leader of the pack, believe it or not, is Aetna.
Yeah.
Aetna is sending mailers out. They have nurses calling patients. They're trying to redirect you from hospitals for whatever you need to try and reduce expenses.
Because we have this great message, high quality care, low cost.
Yeah. And so that may ultimately be the final push for that domino to fall because the payers want it to happen. They can't sustain the cost that they incur for patients for any reason to go into a hospital when it can be done safely and more effectively in an ambulatory center. So that's where I think cardiology is going to end up. But I think, again, if you look, at least in the next 5 years, I would say the greatest percentage growth in ASCs is going to be in cardiovascular disease.
Thank you very much Thank you very much, Dr. Puma, for joining us on the podcast, and good luck. And we'll keep an eye on you and make sure our audience knows what happens when it finally goes through. I appreciate your time.
John, it's my pleasure, and thanks for all the great work that you do.
I appreciate it. Thank you. Then we talked to Chris DeCarlos, and he was with Philips, the instrument or the equipment manufacturers, about the vendor side of cardiology and the opportunities. And Chris knew quite a bit about the national trends in cardiology, and he brought a very different perspective to this. I'm here at the 2023 annual New York State Association of Ambulatory Surgery Centers conference in Albany, New York, and I'm sitting here with Chris DeCarlos. Is that pronounced properly?
Yeah, close enough.
Okay,
better than most.
And he's from Philips. And thank you so much for joining us and talking about cardiology and the future of cardiology.
Absolutely. Appreciate you having me.
So when we were talking before we started recording here, I was talking about my time as administrative surgery center, and I ran largely eye surgery centers in those days. And I could not do it without my friends, the vendors in that industry, the Alcon, the Bausch and Lombs, the Zeiss reps, and they became my best friends. They were not just somebody that was selling a product to me. They were, selling a solution.
Sure, absolutely.
And that's what, and right now, cardiology is the hot topic,
right,
throughout the country. And here we are in New York State, and it's not allowed.
Right.
And we just finished talking to Dr. Puma about from a cardiologist standpoint, why it should be done.
Sure.
And now, but you have a national perspective. Dr. Puma is from New York. You have a national perspective. So New York is kind of an outlier, right? So talk a little bit about the national perspective on this and what's going on in other parts of the country.
Yeah, sure. So Philips has had an out-of-hospital program since atherectomy was started in office-based labs back in 2010, 2011. Strategically focused on, supporting physicians in their exit from the hospital to office-based labs. And, peripheral vascular procedures, venous procedures, et cetera. Obviously, in 2019, when coronary diagnostics came on the radars for ambulatory surgery center, that made us kind of pick our head up and say, well, what's happening here? Are we going to see a similar shift that we saw in vascular procedures with coronary vascular procedures? And then in 2020, CMS allowed for percutaneous coronary vascular intervention, PCI, to be done in ambulatory surgery centers. And so obviously that piqued a lot of folks' interest. Some folks had built office-based labs that were to ASC standard, sort of sensing that this was coming or having knowledge that this was coming. And for them, it was easy to sort of just flip the switch, call it an ambulatory surgery center, get the certifications and start doing coronary procedures right away. But there's obviously some barriers to that, right? Like we talk about New York State, it's not currently allowed. But what we're seeing across the country is that those states, particularly obviously in the South, where there were no restrictions or laws against coronary procedures being done in ambulatory surgery centers, we saw really an explosion.
Yeah.
And we're continuing to see that mostly in the private physician management company, private equity. But we are starting to see the hospital and IDN shift into the cardiovascular ASC as well. The other thing that's interesting is we're seeing these states that previously had laws on the books, like Pennsylvania, South Carolina, shift towards allowing these procedures to be done in the ambulatory surgery center as well. So as we're always planning 3 to 5 years out, we do see more and more states allowing cardiovascular procedures to be done in the ambulatory surgery center site of service. And the other thing that we see is more complex procedures moving towards ambulatory surgery centers over time. Obviously, safe procedures that can be done effectively. And for us, at Philips, it's all about the patient, right? Ensuring that we're really helping them, achieve their goals, getting back to living a healthier, happier life. Obviously, we know in an ASC, lower copays, right? So lower cost of care. So for patients, they love that. They love going to this site versus a hospital and having the procedure done and being sent home, within hours of stepping foot in the facility. Obviously, we know lower infection risk in an ambulatory surgery center than in a hospital. So, we know we can have safer outcomes from that perspective, and that's really what we're focused on is lowering the cost of care, helping our patients achieve better outcomes at a lower cost, and that's why we're so interested in this movement, this shift of cardiovascular procedures into the ambulatory surgery center.
So Ambulatory Healthcare Strategies works in Pennsylvania and New York, many other states too, but I think I was shocked when Pennsylvania allowed it before New York did, because you talk about a state that, their CON regulations are not as strict as New York is, but your ability to add new procedures is definitely much tougher, and and the fact that they've gone in that direction seems surprising to me. What do you think are the barriers in New York? From your experience, have you had any opportunity to look into that? I know you're very active right now in trying to get New York to recognize the value of this.
Yeah, well, I know. Look, New York, it's the Mecca, right? It's so many teaching hospitals, fellowship programs there as well. So, obviously, the hospitals are very big, very, very powerful in New York. That could play in to some of what's happening here. But what I would say is, as PCI first started to shift into ASC, we heard many people in many different states say, that will never happen.
Yeah,
here, right. My state would never allow this. You
kind of what happened with total joints. We're never going to be doing total hips in surgery centers. Now they're routine.
Yeah, exactly. Yeah. Absolutely. But again, we see this shift occurring. And we do believe that in a majority of the states that are currently, there's laws in the books or certificate of need is such a high barrier that folks are even today saying, well, that may never happen. Massachusetts, California, et cetera. We do see over time PCI shifting even in those states which are probably most reluctant to or will be one of the last to allow this procedure to be done.
So, Chris, talk to my audience who is sitting there saying, I've been doing eye surgery for years. I've been doing GI procedures for years. I've been doing arthroscopies for years.
Yeah, sure.
I've never touched a heart. I don't want to be anywhere close to that. That's got to be scary, to me. What type of barriers? Now, the first thing I'd say is, obviously there's a lot of support out there. This is being done out there, but what is your answer to that? Speaking from a vendor standpoint, and the support that would be provided to them.
Sure. Well, what we've seen in ambulatory surgery centers in a similar situation do is just bring in a coronary C-arm, a cardiac C-arm, and start to do some very basic CRM procedures, like pacemakers or battery changes, right? Yeah. That way you don't have to dive into the deep end of the pool, right? You're just dipping your toes in to see, is there a physician who can come and do those procedures? Is the referral network robust enough, right?
Yeah.
And then you can decide, is it worth the investment, right? Because we know converting an existing operating room to a cardiovascular lab, not even counting equipment, is going to be close to $1 million, right? And then obviously all the devices you'll need to bring in to support those PCI procedures. Most companies will consign a majority of those products, but you will have to purchase some devices as well. I think there's ways to sort of lower the barrier and start small and grow into that facility where you're doing PCI and you're equipped to do the future cardiovascular procedures. But I mean, we do know that cardiovascular is the fastest growing ASC specialty today. And we do know that the payers, United Health says that a shift of cardiovascular procedures to the ASC will save the healthcare system 59% from an expense perspective, right? So we know the payers are very interested in these procedures shifting.
And Medicare recognizes that. They're already starting that process. If Medicare, if we can save the Medicare program that money, you can imagine what can happen with the private insurance.
Absolutely.
Yeah.
I get that it can be a very daunting. I've never touched a heart, and it's scary. Yeah. Obviously, you refer to physicians for their thoughts there, but I think obviously you're going to take your safe procedures there initially. You're not going to be doing complex PCI. You're certainly not going to be taking call and bringing in heart attacks right into your cardiovascular ASC. That's just going to be reserved for the hospital. But obviously we do see this shift occurring broadly across the country. And listen, even in the states where it's wide open, there's still some provider hesitancy, right? We still have some physicians that are unsure whether this shift to the ASC, whether they should take part in it. But by and large, particularly the independent cardiologists have really started to lead this movement. And we are starting to see IDN and hospital engagement as well. And so that's starting to pick up as we sort of anticipated it would. And we anticipate seeing more and more of that over the next few years.
Now, it's scary, $1 million price tag for the equipment. But the financing of that's probably that's a barrier you can get over relatively easy, as long as you have a strong financial plan. Christy is also with us. She's off microphone, but we were talking about feasibility studies, which are so important, in order to determine that, financially this is viable, and it will be viable. There's no doubt about it. But speaking as a former administrator and now working with a lot of administrators, and as a finance guy, I can get past the problem of financing all of your wonderful equipment. But what scares me is, what am I going to have to do with my operating room? How long am I going to be down? What's going to be involved in the infrastructure there? Can you talk a little bit about that? And what would be involved in, let's say, we've been talking a little bit about eye surgery, for example, moving out of ambulatory surgery centers in the next couple of years. This is an alternative here. What would it take to assuming that you've got a properly sized room in the first place?
So ACC is calling for a minimum 600 square foot room.
Okay, so that is much bigger room.
It's a bigger room than there is
because of the equipment that you're putting in there.
Right. You have your four different sections, and you need the space for the equipment.
Okay.
You're going to have a large C-arm in the room. You're either going to choose ceiling mount or floor mount. That's really physician preference. Most often we're seeing ceiling mounted systems. So you're going to need rails in the ceiling. Yeah. You're going to need radiation shields, lights in the ceiling, et cetera. You're going to need to have a control room, so a separate room where you're doing your monitoring with a leaded window, leaded walls, so that radiation is not escaping that room. About 120 square foot there. Okay. And then you're going to need a room for your equipment, essentially the guts of the equipment, your servers, et cetera, about another 120 square foot room for that as well. And so, when I talk about, $1 million not counting equipment, that's really what I'm referring to, converting that existing operating room to a cardiovascular operating room.
And it's likely you're only going to need one for the average surgery center. Is that true? Unless you're super high volume. And
de novo cardiovascular ASCs, what we're seeing happen most often is they're hanging one fixed system in one room, and they're building the second room with the technology to do that in the future, but they have a cardiac C-arm in there, and that's where they're doing their CRM, waiting for more complex PCI procedures to come or looking at their volume. But yes, existing ambulatory surgery centers that are adding a CV service line, we're seeing one room. But to your point, during construction, that room is down. You can't use it to do your other procedures. And so that does create a challenge. And I think that's where you guys come in and can show sort of cost benefit analysis to say, hey, you're down for this long, but here's what this looks like once we're open, right?
Right. And I think as as all of us are contemplating the future of certain procedures that might be moving in, the opposite direction yours are, moving into the OBS environment.
Sure.
We're going to have to make structural changes. We're going to be going through construction. We might be expanding, for that matter, or we might be contemplating building a new surgery center for multi-specialty.
Sure.
I think your message is very important. Even if you don't think you're going to be doing cardiology now, build that 600 square foot room. Have that extra, I think I just added up 240 square foot for a possible future control room and storage or equipment room. So that, because the cost now to add that is going to be far less than the cost is going to be to retrofit an existing center down the road. So think about it.
And it boils even down to parking, right?
Good point.
Do you have enough parking spots per the requirements, right? Yeah. So oftentimes when an ambulatory surgery center adds a cardiovascular service line, they need to add parking to their facility. And if you can't do that, that creates a barrier there as well.
Especially with local codes, we usually demand a certain amount of code spaces based upon the size and the clients that are coming through.
Absolutely. Absolutely. So yeah, those are some of the challenges. Obviously, HVAC, stainless steel HVAC. All of those different things that might be different than when that ASC was originally built and having to now go back and retrofit the space. So, but there's experts obviously, and we obviously point to those experts when our customers are coming to us and thinking about that service line. Is there's experts in the room that can do an analysis for you and walk you through the process and what those next steps might look like.
So the future is upon us. Now New York isn't yet there, and you're working. Thank you very much for working on behalf of the industry to get this over the finish line there. But for those of you that might be listening from other parts of the country, it's time already in many of these states. So start thinking about it, and Medicare will continue to add additional procedures to that list that can be done.
Absolutely. It wasn't more than 24 months ago. I sat on a panel where we were asking, has the boat left the dock yet, right, on the shift of cardiovascular to the ASC? I think the question we're asking now is, is it a sailboat or is it a speedboat?
Yeah, that's
right.
Yeah.
And so I think time will tell.
Yeah.
But we're certainly starting to see signs in the market that are encouraging from a shift out of hospital to ambulatory surgery center perspective. It appears as though the shift is happening and ramping up as we speak.
And we need to be prepared to be able to deal with that.
Yeah, that's right.
I appreciate it so much, Chris. Thanks for joining us.
Thank you so much. I appreciate it.
And Luke Wright and Anna McCarthy provided a legal overview of human resources in New York State.
And this, I talked to them during this interview about how much feedback they got during this this session. So
I was in that session.
Oh, that's right.
And they got stuck on like slide 2 or something.
Right. I don't think they were able to get through all the slides. But.
Yeah, it was great. There was so much participation, and they had a lot of good information.
And they're very enthusiastic speakers, so we're definitely going to be hearing more from them. Yes. And they also joined us for the 2023 multi-state conference, and we'll probably invite them back for 2024 also. So let's listen. This is John Goehle. I'm at the 2023 annual New York State Association Ambulatory Surgery Centers conference here in beautiful Albany, New York. I'm here with actually my lawyers for my company, and it's so great to have you here with me, Luke and Anna. And this is an opportunity to talk with lawyers about their favorite topic, which is employee law. So you just finished a session for our audience, and like I predicted, there was going to be a lot of audience interaction. And a lot of questions, and I think you said you could talk for another couple hours, right? Easily.
Yeah. So. For sure. Before we get started, John, just want to note that although we are your lawyers, attorney-client privilege will only attach if no one hears our conversation. So is this do you have an audience for this?
Well, we're not going to talk about my company, but...
Okay. All right. Yeah, thanks for having Anna and I here. We just gave a session on all the employment laws an ASC might need to know.
We covered every single one of them.
and we were waylaid one slide in with nonstop questions from the crowd. So it was really, really incredible.
And I should point out that you also spoke for 2 hours during our multi-state conference, which is available to all of our listeners on ASCPodcast.com. If you're a member of the New York State Association, you would have been able to. Hopefully you joined us for free at that point. It's no longer free, sorry, but we're already planning 2024's multi-state conference, and that was a great discussion that you had. But it wasn't. That was not focused on New York State. So what your focus today was on New York State. So what I guess a good question to ask, instead of focusing on what your presentation was, talk a little bit about the questions that people were asking. What's on their mind right now?
So we got stuck on the New York State law update slide, the slide that talked about what happened in the last year in New York State. And every year there's a barrage of new laws that employers have to worry about. I think one of the bigger ones that everybody was focused on was the protection that attaches to taking legally protected absences or taking an absence from work that's protected based on maybe it's the FMLA, the New York State Paid Family Leave Law, the New York State Paid Sick Leave Law. And basically that new law says that you can't retaliate or take adverse action against someone for taking protected leave. Yeah. So that means that if you've got an attendance policy where you assess a point against someone for taking a sick day, you can't do that if that sick day falls under New York State paid sick leave, protected leave. So that changes a little bit about what employers do.
Yeah.
Really, because the leave was protected in the first place, we would already have been a little hesitant if an employer comes to us and says, I'm going to discipline someone because they've taken leave under New York State paid sick leave. But now it's officially codified in New York State law. So something to be aware of.
Well, to that point, one of the things that I think happened with COVID too is we changed our whole mindset. It used to be, well, you're coming to work whether you're sick or not, right? And that's not the way it is anymore. Anywhere, it's not just healthcare. You don't go, you're sniffling and you're out of work for a while.
Get the side eye.
That's right. That's right. I have this ongoing cough because of my allergies. Most of the time people, move to other tables in restaurants, which actually I kind of like. But of course that it causes some problems. But to your point, it's already naturally because we can't get rid of these employees anyway, because we're lucky to have them working for us. So we're going to do anything that we can to keep them on board, and we don't want them to come in when they're sick, whereas in the past we might have allowed that. So that's interesting and very good point.
And in New York, we have not just paid sick leave, which is relatively new, right? They're required to have a minimum amount of paid sick leave, but we have paid family leave, an insured benefit to take care of family members or bond with a newborn. We have disability benefits. And
I want to personally thank you for that, because two of my employees, based upon the write-up that you've done in my employee handbook, are taking that. So thank you so much for doing that for us. I mean, I love it. They're relatives of mine, so that's great. But it's a great benefit, but you're right. It really adds a really significant problem for many organizations and staffing.
Yeah, and that kind of a law applies to New York employers regardless of size.
Yeah.
So the federal law, you have to be at least 50 employees. This state law, it doesn't matter.
Yeah.
And it's a job protected and it's a paid benefit and it's a really great benefit, but can present management problems.
Go ahead.
Especially when you're on the smaller side, because you're worried about coverage. If you've got one individual performing one job and they're taking paid family leave, they're not out forever, but potentially up to 12 weeks.
Yeah, and that was the question I was going to ask, is how does it, what were the types of questions? I'm sure that was it, is that we're not deep in these organizations. Many of our surgery centers are very, tightly staffed, and we can barely make it by right now. We can barely find anybody to do it. And we want that person to come back, and we want to hold a job for them. But in the meantime, how are we going to find somebody that's going to be able to do all of that work at a high quality of care by telling them that they're going to be gone in a short period of time? And it really gets down to, there's actually a session that was done earlier. I didn't have a chance to interview that person. It was talking about cross-training and how important it is now to cross-train almost every position you have in your organization.
Something, John, that we didn't really dig deep into, but is a new New York rule, is the new job posting wage transparency law.
Yes, thank you.
Which
Talking about that.
I don't know if you're looking for another job, but when you look now, it's very interesting, right? You have to have a good faith salary or pay range posted with a job, and it's a big change.
We were in Illinois doing an episode in Illinois, and they have a similar law. And they during the interview, they pointed out, I don't think I actually interviewed, but during the session I was reading it, I passed the news on that they said that, oh, by the way, New York has it too, and I didn't know anything about it. So, so what does that mean for us?
Well, so the basic requirement is that you've got to change the way that you're drafting your job postings.
Right.
And maybe you don't because you've already been posting a pay range on there. But if you haven't, you've got to include a minimum and a maximum pay range that you're going to pay within this particular position. It doesn't mean that you can't decide if you've got an excellent candidate and they ask you for a bigger starting salary. It doesn't mean you can't change your mind at that point through the hiring process.
So it doesn't tie you to that range, but you have to do a fair calculation.
Exactly. Specifically, it's called good faith. So you have to have a good faith range in that job posting that you're going to pay within. And then again, you can make ad hoc decisions later to change that, but consistency is really important because you don't want to be making ad hoc decisions based on a protected category, like only negotiating with men that apply, for example, versus women.
And that's the purpose behind the legislation that generated this, I understand now.
Exactly. It's tied to equal pay for equal work. It's sort of all all falls under the same umbrella. Now, the other consequence of this law that isn't specifically related to the job posting requirement and the obligations to put that information in the job posting, and you also have to include a job description, by the way, if you've got one for the particular position. But the other consequence is now you've got current employees seeing what...
But that's what all the questions were about, right?
Exactly. And you can't avoid those questions, but what employers can do is proactively figure out what they're going to say when they inevitably get that question. Right. And it's going to require employers to think about how to address those problems. Are we going to tell them that, look, we're raising everybody up to that level as of, October, but we had to wait, fiscally we couldn't do that within our budget, but we're going to as of October. And that's when we're hiring someone new. Whatever it is, I think take a clue from the law's title and be as transparent as possible. It's the wage transparency law. It makes sense to be as transparent as you can to avoid problems, I think, going forward.
And you probably should be consulting with your lawyer. I hate to give any more business to you guys, but I'm being mean to you today, aren't I? But it's important that at least the first time around you get some assistance.
It couldn't hurt to have somebody familiar with the law as Anna is to take a look at those postings and just make sure that we feel okay that there is a good faith range, there's enough of a job description to meet the requirement, and that we feel okay about it. And it really just changes the landscape. Poking around on whether you're on LinkedIn or Indeed, just to see actual ranges, it's strange.
Well, it's actually going to make my job easier when I'm doing feasibility studies and I'm trying to figure out the what people are being paid. I mean, in some ways, let's look at the positive side of it. Now you're going to know what the competition is doing.
Yeah, exactly.
And we never had that data before, so let's lead with that. Good news, you're going to know what the competition is going to do. Bad news is they will know what you're doing also. Mm-hmm. What else did our esteemed audience ask? Well,
we got hung up a little bit on marijuana. As our presentation.
So you're just passing it around
our presentation ended at 4:20.
And at 4:20 on the dot, we got a question about marijuana.
So as you probably know, John, marijuana is lawful recreationally, right? In New York. Yeah. And along with that law came a law that specifically said that employers cannot penalize or hold against employees their off-duty lawful marijuana use. Yeah. And then the flow down, of course, always if somebody is under the influence at work, or you could prohibit use at work and on work property or with work materials. But subsequent guidance, right? You can't hold people accountable or discriminate against people for using marijuana off duty. Is an explicit requirement that you are not to test for marijuana, upon hire or really any time, unless the government specifically requires you to test for that position, like say DOT drivers, or you're specifically required by a federal rule or federal contract, and those are kind of few and far between. So we got some questions around, is that right? What if my employer is doing it, and just sort of talking through those issues.
So just. We know if somebody shows up that's inebriated, of course, we have the right to, terminate them. It's what we refer to in our industry as an incapacitated provider or employee. Mm-hmm. Are those rules different, or is it, I guess you can find out if somebody's inebriated a little bit easier than perhaps under the influence of marijuana. I don't know.
Yeah, it's harder, right? And we did get a question sort of to this effect, which is, what if I really think that someone is under the influence of marijuana? They look like it, they smell like it, they're
not acting normal,
it. What do we do? Yeah. And I think that you raise a good point. If we think someone's been drinking, we can smell alcohol, and we can require a breathalyzer, right? And a breathalyzer will be accurate and say what's going on. And the same isn't true with marijuana, right? Yeah. It can be hard to really be certain. And our guidance there, often would be, rather than make the decision point around whether or not the person is actually under the influence, make it about their performance. Yeah. And if they are not performing timely, not responding timely, doing things that are unsafe, repeating work. Yeah.
discipline that.
Or you're
Separate
having
from
problems
that.
with other employees.
Don't get in an argument about whether or not they're under the influence.
Yeah.
Because
look at the effect, not what the cause was. Got it.
And we think that's often a better approach.
And probably even with alcohol for that matter. So, it's just a little bit easier, I think, with alcohol.
I think it is.
Yeah.
It is easier with alcohol.
So what else?
We did get a question about bullying, which I thought was interesting.
Question,
so New York State has some pretty specific requirements around sexual harassment. You have to have a policy on sexual harassment. You have to train all your employees on anti-sexual harassment policies and procedures on an annual basis, and as soon as possible after you hire them as well. And so we got a question about bullying. What do we do if we get a complaint about bullying? And the quick answer is you look into it. Yeah. So just because you get a complaint that doesn't have to do with a protected category on its face, someone isn't saying she doesn't like me because of my religion, something blatant like that. But you have an interpersonal conflict or something that is just not allowing your employees to work cooperatively. Yeah. The important thing is to investigate it without making assumptions about whether or not it's a meritorious complaint. Yeah. Because what you don't want to do is ignore that meritorious complaint and then have it blow up into a bigger issue later on, and inadvertently create a hostile work environment because you've allowed complaints to go unaddressed. Right. So I think, again, the bottom line is to make sure you're investigating those complaints. It doesn't have to be a full-blown investigation where you're talking to multiple witnesses, you're looking at text messages. Yeah. Maybe it's just a conversation with the employee who complained and the person they're complaining about. But looking into it and then documenting that you looked into it, when you looked into it, and what the outcome was is going to be really important if the complaint ever comes back later on or you get another complaint about the same employee.
So I guess my comment being somebody that deals with quality improvement all the time, that's exactly, and for our listeners, that's exactly what we do when we're talking about incident reporting. We're already used to doing it. I'm sure many of your other organizations that are not in the, that are not like an ambulatory surgery center are not used to that, but we are. So just think about that, similar process, not the same process, obviously, because it's much more protected. But
and for these employment laws, the actual law that's on the books, right? No discrimination based on religion, race, gender, et cetera, in New York. That's a floor. And so when Anna says we got a question about bullying, it might be about someone's favorite football team. Yeah. Right? And it's not illegal. Yeah. But that doesn't mean that we can't have expectations around how people treat each other and work that are higher than the floor that the law sets. Just like with a minimum wage. That's a floor.
Yeah, doesn't mean that's not what you pay.
But that doesn't mean that'll get people hired and working. Right. So we can go above the floor of the legal requirements that we have.
So, anytime I talk to lawyers about employment law, there's always an elephant in the room. And it doesn't matter what state I'm in, but in New York in particular, our nurses they work very hard. And sometimes they just don't have coverage, and sometimes they just, they say, I got to work through my lunch hour. Can I do this? Can I go home early? And it really presents some unique situations, problems in New York. So now that I got two lawyers here talking about New York in particular, help our audience understand what that really means and how you realistically deal with that situation.
So I think the basic rule, I'll start with the basic rule, and then maybe Luke can jump in, is that if someone is working through their lunch break, they have to be paid. Yeah. So even if typically your practice is someone takes an unpaid lunch break, if it's not uninterrupted and they're ending up having to ditch that lunch break because something came up, they have to be paid for that. So
or they're eating and working at the same time.
Exactly. Exactly. It doesn't matter if they're actually getting their lunch in their mouth.
Privately.
If they're working simultaneously, they've got to be paid for that time. So that's the basic rule and the most important rule in this case.
Okay.
Yeah. I think that's exactly right. New York law generally requires that people be given 30-minute uninterrupted break for their meal period.
Where they're completely relieved from their responsibilities and are not interrupted by somebody else.
Yep, and that can be unpaid. Right. And that's a rule. There are very limited exceptions, and that could be where someone is the only person there and on duty available to do the thing. There are also many times, practically speaking, where people don't get that lunch either at the right time or it's not interrupted. Yeah. And Anna is exactly right. The biggest misstep you can make is
is they didn't get
Failing
the
to pay
lunch,
for it.
but and you're not paying them.
Yeah, right.
Right. If
right.
you're paying them and you recognize that it's an exception and it's unfortunate, but you pay them for the time they worked.
Yeah.
Then I'd also add trying to correct the issue by either on a go forward or even that day. You weren't able to get your break during lunch, but now you can go.
Right.
Right. That's helpful too. But the key is if people are working, pay them. That is a bigger concern. It would make us lose more sleep than the missing the break or the not getting the full 30 minutes.
Yeah, it's
the
very
pay
good
issue
advice.
is the bigger one.
Yeah, and I think from my standpoint as a surveyor, one of the things we always want to do is just make sure that we identify these problems, document them, be upfront about those issues, rather than have somebody put an interpretation on which was not what really happened. So it's far better to explain it, write it out, explain what you did in order to fix it, make it very clear that you paid this person for that time, and while it might not have met the regulation, you did everything possible to mitigate it, and then also try to find a solution later. That's the whole concept of quality improvement.
Right. I think it's important that, as Luke mentioned, that it's the exception to the rule, that somebody has to work through their lunch break. So making sure you're not scheduling with people such that it's impossible to take that uninterrupted paid break, or rather
be able to document that
unpaid break.
and be able to document that you did build it into their schedule, that you never anticipated. That's a good point.
Exactly.
I want to thank you both. I know you were heading back to Rochester, our respective homes, and I appreciate your time here, and have a safe trip home.
Thank you for having us.
Thank you.
Thank you, John.
And the next interview was with John Morley from the Department of Health, and Lisa Altieri was there and kind of helped out with the interview. She did much of it.
She did actually ask most of the questions, so that was a good approach to it. So let's listen to Dr. Morley. This is John Goehle. I'm here at the 2023 New York State Association of Ambulatory Surgery Centers annual conference in Albany, New York. I'm here with Lisa Altieri and Dr. John Morley, who is with the New York State Department of Health. And so we're just going to have a dialogue. You just finished a session here at the State Association meeting, a very well-received session about the relationship between the Department of Health and our state ambulatory surgery centers, as well as the association. Go ahead, Lisa.
So thank you. And thank you, Dr. Morley, for coming today for another session. Everyone's always excited to hear from you, and you are funny. One of the things I think we asked about was, ambulatory surgeries are starting to actually come up, and more are getting opened in New York State, but we're still 47th in the country with the number of ambulatory surgery centers we have per 100,000 population per capita. One of the questions we had asked you to speak to today was, where do you think and where do you see healthcare going in the future in New York?
Well, Lisa, thank you very much for asking me to be here today, and thank you very much for the question. So we have a huge system, and some people argue that it's actually not a system. We refer to it occasionally as an open market or free market environment. What we would like to see is more of a system. Ambulatory surgery centers are an absolutely critical piece to this. They provide efficient, effective care in the environment that's more local to patients frequently than hospitals are, and an environment that patients greatly appreciate. So there's no question that they are an important part, critical part to the system. But we need to be thinking more as a system. We need to be recognizing that patients have been falling through cracks. The IOM report in 2000 spoke about the quality chasm, and each time patients would have a problem, it was frequently in the gap between entities. So what we're looking to do is identify mechanisms such as value-based contracting, value-based purchasing, where you bring all of the pieces to the puzzle together, everyone that's going to be providing care to the patient, and you make sure that you have warm handoffs and that the patients aren't falling between the time that they leave one office and enter the next office, that things are as smooth and efficient for the patient as can possibly be. We're happy to support the increase that we're seeing and the ongoing increase in ambulatory surgery centers. We see the insurance industry is incentivizing this, and we support that. So I think ambulatory surgery centers, are a focal point of your attention, one of the pieces that we believe to be critical to creating the system going forward.
And what do you think? The certificate of need application process in New York State, of course, is a bit of a limiting factor. It always has been, but it has definitely been much easier to get a CON in New York. As a matter of fact, just looking at the growth of ambulatory surgery centers over the last 5 years, we were less than 100 for much of my career in the industry. And now we're inching up close to 170. Where do you think that process is going in the near term, or even in the next 5 years, with regard to the approvals and the types of surgery centers we're going to see approved?
So it's funny you should mention that. So we are looking at our CON process right now, and we are trying to figure out how we can make it a little more efficient and smoother. It is, a bureaucratic process, and one that I don't see going away in New York.
That's correct.
But, we're at the same time that we're attempting to smooth the process out, it also has been identified as a focal point for people to enter into the system so that standards could be set, and at that time, as an entity comes into existence in New York. For example, the legislature passed the bill requiring the healthcare equity assessments to be done. So there's opportunities at the time that an entity comes into an existence that's ideal to provide information and to set specific goals and targets. But that said, we are trying to make the process more efficient as we possibly can. Some of that will be through technology, and some of it will be looking at what we think are the critical pieces and what's not critical, trying to eliminate some pieces.
One of the things many of the members and the physicians in all the specialties are looking at is actually having a little bit more independence in their scheduling and how they actually can really spend more time with their patients and actually give the patients great outcomes and customer care. And so they're looking at doing different types of procedures. Cardiology is one area, but we are looking at different opportunities. Where is the department on that?
So right now we're aware that it does exist in other states, and that there is
You talk about cardiology in particular here, yes.
Correct, cardiology procedures. So we're aware it does happen in other states, and we await somebody to come forward and bring it to our attention here in this state. And we would have some questions about it. We're not against the idea, but we do want to know, while we're aware that it's happening, we don't know what the outcomes are, and we'd be interested to find out what those outcomes are, and we'd look to see how the pieces are being assembled. How do you risk stratify patients for this so that patients that would require standby surgery or a procedure with additional resources aren't going to this setting, but that you do the patients that are otherwise, comfortable in that environment and not getting not in need of any additional resources.
So that's one area, but we know there's a number of areas that, I know in my history and Dr. Morley, I know you're dealing with right now, is there's a number of hospitals that aren't actually making money or losing money on like labor and delivery is a big area that we know. And so that is something that during COVID, we tried to get some of the healthy births out of the hospitals and possibly do them in ASCs that were shut down at that time. Where is the department in thinking outside the box and some other opportunities in regards to some of those specialties that the hospitals say, they're losing money on?
We are always interested in people and ideas that are from out of the box, always. Many of them turn out to be terrific, but not all of them. So the devil is being in the details. We'd be looking again to see how patients are being chosen, and we'd be looking to see what resources are being applied at the place of the location of care. So it's a concept that I'm not familiar with actually happening, but I'd be interested to learn more about it for sure. And as I said at the beginning, we're always interested in out-of-the-box ideas. I think, the problems that we have today are not going to be solved by the solutions of yesterday. We have to be thinking new.
Right. I think one of the things that the association really wants to thank the department is that there is now the acknowledgement that the Association of Ambulatory Surgery Centers exists, and we want to continue to partner with the department. And that is very, very obvious from you, from your division, from actually all the divisions. And the Commissioner McDonald was with open arms, very supportive of ambulatory surgery centers. We want to continue to do that, and we want to be a resource to the department wherever we can. So we're going to continue to try to approach you and bring some of those ideas to you.
And we need to make clear, too. I mean, I've been in the industry 34 years now, something similar to that. And, from the very beginning, the department has been great. But the response in the last couple of years has really been, dramatically different. A lot of it, of course, Lisa, obviously your relationship with our organization, your relationship with the Department of Health has been gratifying. But having Dr. Morley, who is really, very actively engaged and understanding of our industry has been very helpful too. Now that you know that we're different than ambulance services, and as we used to joke about in the past. But
we look forward to continuing a long-standing relationship between the department and the association.
So there was kind of a humorous question at the end where they asked, what is the Department of Health doing? So I'll just bring it up, doing to incentivize ASCs, and I thought your answer was very, very good. I'll just tag something onto it after you give the response that you gave to our listeners today.
So the department is a huge supporter of of wanting to see an increase. We recognize that the numbers in New York State compared to other states is low. We are receiving applications. The applications are for new ambulatory surgery centers and expanding current ambulatory surgery centers, and both are excellent, and we're fully supportive. We recognize the insurance industry is incentivizing the addition of ambulatory surgery centers, and we're supportive of what it is that they are doing as well. If you have additional ideas, we're more than open to hear what those ideas are that we could do to provide additional support.
And I would remind our listeners too that that's where we are. I've gone through like 5 cycles of applications being put on hold because the hospitals were fighting those applications. We're just not seeing that generally except in very specialized situations. So my answer, if I were you up there, as I say, we are incentivizing by making sure that application, the CON process, has become much smoother, and that our the people that are coming up with innovative ideas such as the cardiology or vascular access, of course, that's a huge change with those organizations finally getting the approval. Though we do want to see some 4 more get across the finish line there to really improve access, and that's what it's coming down to, is that we have an access problem right now, and we have a solution. We just need to get these things past the finish line so that we can improve that access to our patients.
Excellent.
I want to thank you so much for joining us. I think this is the first time we've actually had anybody from the Department of Health on the podcast, so I appreciate your time.
Pleasure's mine. Thank you for having me.
Thank you.
And lastly, I had an opportunity to interview Lisa Altieri, who is the president of CHC, which is the company that manages the New York State Association's legislative efforts. And we've talked about a lot of different things related to the State Association and its efforts on behalf of the members. And Sue, I had so much fun talking to her that I promised her that she would be the last interview, kind of leaving on a very positive, upbeat note. So let's listen.
This is John Goehle. I'm here at the 2024. We're here at the 2023 annual New York State Association Ambulatory Surgery Centers conference here at the wonderful Desmond Hotel. They have treated us so well, haven't they, Lisa?
They have.
Here
It's been wonderful.
in Albany. And we're in your backyard. Luckily, you don't have to go very far to come to this conference. And I'm here with Lisa Altieri, a dear friend and a dear friend to the ASC industry. And Capital Health Consulting has been an incredible resource to the New York State Association. So thank you so much for everything you do. As we were getting ready for this, we're trying to figure out what we're going to talk about, because we literally could talk for 3 hours about everything. And of course, I've done all these interviews. You haven't sat on all those conversations. So we thought we would just have a conversation about, what's going on with the state. And, so as I'm thinking about some of the issues that we're running up against, a big theme during this conference was our anesthesia crisis. And we were able to talk to a lawyer about the anesthesia situation, but that's a lawyer's perspective.
Exactly.
And we were also talking during the board meeting, and we were talking offline with you, that this wasn't a situation that occurred slowly.
it just came upon us very quickly. And that's not actually terribly normal in our industry. And of course, there's two parts to this that I'm worried about. One is the anesthesia crisis itself, but what else is on the horizon that could happen too? So, so you've seen what's been happening, the challenges that we're having, some of the difficult conversations we're having about the role of CRNAs, the role of conscious sedation nurses in the surgery center. I just want your take on where we should be going, what we should be doing, and is there any hope for a quick solution to this?
So I hate to say, you are absolutely correct, 110%. This went from we're hearing about the issue to where 95% of the facilities are starting to say we're having a problem. Right. So you're absolutely correct. Yeah. Is there a quick solution? Probably not a quick solution, but I do think there's a few things we need to start to focus on. One is, in Albany, there's been a lot of push for scope of practice and pushing scope of practice for a few reasons. One, COVID. Yeah. Two, the hospitals actually want the PAs and the MPs and the CRNAs to be able to do more without supervision from the physicians. Physicians cost more money, so they're pushing them out after purchasing up all the little small groups. Right. On the CRNA, there's two bills out there right now in Albany. One is to actually acknowledge and license CRNAs. Yeah. The other one.
Well, let's stop for a second because I'm not sure all of our listeners completely understand that. Yeah. But when we verify the licensure of a CRNA in the state of New York, all we get is an RN license.
Correct.
And in many other states like we're in, there is a specific CRNA license. So we can't actually verify that they're a CRNA until we go to their national organization. So I just want to clarify that.
Now, that's a great point.
Yeah.
So that's the first bill, which I think everyone in the state's very supportive of that, right? We really need that to happen. Yeah. But the second issue, which is really going to come up with a lot of the subspecialties and the specialties saying no, is they want to be independent of the physicians. And in all honesty, all of the specialties, the plastic surgeons, the dermatologists, and, there's the orthos, they're kind of questioning if that's really what we should be doing. Because we're thinking, do you want to lower the standard of care because of post-COVID, what we're learning? Or do we want to kind of stabilize it and look at other things that we can do? And so I think, number one, support the bill for CRNAs and the licensure of them and recognizing that. And second is, where are we as groups to actually come up with some good ideas, to actually give them some independence? Does it mean over-the-shoulder supervision? Does it mean in the next room supervision? So that's one thing.
Well, and I think to that point, the issue is we're not questioning the qualifications, the capabilities of the CRNAs. It's actually more the person that's supervising them.
Exactly.
Right. I mean, we have no doubt that an anesthesiologist can supervise it. And I'm an ophthalmology guy from way back. I love that profession. But do I want the ophthalmologist in the room doing a code? Probably not. And nor do they want to do that. Right. So the supervision of an ophthalmologist over a CRNA, that's questionable. Whereas on the other side, maybe a GI doctor who probably has a lot more experience in that sort of thing would be able to do it. But those are hard things. How do you start to separate out that, which type of doctor? They all have MD degrees, but which ones are going to be the proper ones supervising? And that's a conversation that we're going to have.
And that is one conversation that has not come up when I'm talking to all the specialties and to the medical society. That isn't something that they've been talking about. Right. It's yes or no.
That's right. That's
it's
a straight
supervision,
answer.
Right? And so that's funny that you actually raised that.
Yeah.
The other thing is, in the conversation with anesthesia, honestly, going back to Dr. Morley, is really what drives healthcare is the dollar.
Yeah.
And so it's expensive. And why is it expensive? Because more and more physicians are leaving earlier than they would. They would continue to practice if it wasn't so hard in New York State.
Yeah.
Med-Mal, Grieving Families Act, and some of the other things going on is really kind of pushing that.
And quality of life in some areas. And, you can go to some wonderful places with, with better cost of living than here. And here you just have to earn so much more in order to be able to, get the quality of life that you're looking for.
Exactly.
It's not an attractive state necessarily all over anyway.
And the safety down in the city has become a huge issue, not just in the city, but out in Buffalo. Right. We've had a lot of issues happen.
I live in Rochester. It's one of the highest crime, murder rates in the country. Nobody knows that,
I didn't know that.
Yeah. So, yeah.
And I live in Rochester. I haven't seen that, but that's something people are thinking about when they're looking at the newspapers, when they're looking at quality of life issues.
And so the new residents that we actually train, one of the largest areas, right, the largest number of physicians, they leave our state. Yeah. And so I've heard from some people that they're actually asking for more GME slots in New York State, but we have a lot of empty GME slots.
Yeah, interesting.
And then when the people come in, they leave. Yeah. So that's one big issue. And then the other issue in regards to reimbursement that came up today and has been coming up for over a year or two has been, one, the amount of money that the ASCs get reimbursed for versus what the hospitals get reimbursed for. We also mentioned today to Dr. John Morley is that under Medicaid, an ortho does not get actually the prosthetic reimbursed or the supplies. So he's like, well, let's talk to the Office of Health Insurance Programs about that.
Right.
So there's a lot that really has to happen. We have a lot more to go, right? A lot more to do in regards to talking to the department, educating them on what we do now compared to what was done in the 90s.
And I think there's definitely been a sea change in the way they're approaching this, that they are listening to us now. And it's not that, I've never had a bad relationship in any way with the Department of Health, even when I was the president of the association. Yep. They were all very gracious. They just it wasn't anywhere near the top of the radar. It wasn't even, it wasn't even on the radar. And now we have visibility and now we're part of the solution. And for all the terrible things that happened during COVID actually was a moment when we suddenly became important in the state and part of the solution instead of a problem. Right. And that's the one thing I'm always trying. I'm that glass half full guy. That wasn't great, but there are some positive things out of it. And we know that the hospital situation. I was telling you the story. My mother was in the hospital, just a couple weeks ago. 100% occupancy in September. The flu season hadn't even started. RSV isn't even out there. 100% occupancy. She's on a stretcher in the middle of the hallway in a hospital that is fully occupied at this point. And we're not in COVID anymore. So we're not ready for the next crisis there. Yeah. We need to find ways to get that pressure off the hospital and make that hospital taking care, doing those things that they have. I've said this before over the years. I want to see regular hospital occupancy rates at 70 to 80%. And I'm an efficiency guy. Okay, I get it. But I want it at 70, 80% on normal so that they don't go at 180% during a crisis.
So, one of the things, so you're right. COVID really made this association really come together as a community.
Oh, absolutely.
We got on daily calls every day to make sure we were trying to get the most information out there. The other side of this was prior to COVID, the association really wasn't on the radar for the Department of Health. They didn't know that this association existed. But they're becoming more and more reliant on trying to get the real information from the association, which is excellent.
Yeah.
The idea of hospitals being efficient and nimble is an oxymoron, and I don't think it'll ever happen.
Correct.
And so one of the questions we've been having and discussions we've been having at the Department of Health is how is there a synergy between ASCs and hospitals, and which is why we want to be at the table for emergency planning, pandemic flu planning. I've already been talking to some of these folks like, okay, we got to get ready. We're not done. And the plan that was developed in 2008 wasn't really implemented. It was implemented differently because things have changed.
Right.
We have to be more nimble, and ASCs can be much more nimble than the hospital. So there's a lot of discussions, that are going to be happening right now. And I think you're going to see a lot of change. I think we're at the tipping point, which, by the way, was one of John Morley's favorite books, The Tipping Point.
I see yours talking about it.
And it's just one of those things that I think we're there now.
And I think our position, and again, hopefully our listeners have heard this by now, but we have in front of the governor right now a bill to provide a seat on the FIPIC, which is the
Public Health and Health Planning Council is the council that the Department of Health, once they've approved a CON, bumps it up to establishment committee
Right.
within the Public Health and Health Planning Council, and then Public Health and Health Planning Council has to approve.
Right, and we've been wanting to be there for a long time. And truthfully, I mean, I remember in the early years there was absolute animosity sometimes against these, and that's not been the case. As a matter of fact, we just had a CON in front of the Public Health Council, and we always put somebody there. 90% of the time, I was there for one of the meetings, and they didn't even talk about our project individually. It was part of a group, and 5 minutes later we're out the door, which was nice, but kind of a big expense for very little glory during that meeting. But we're appreciative of the fact that now it's becoming so normal. There's not even a question about that. I think having us on the council will provide not only a voice on the voting of those, which is important, but also the ability to discuss some of the issues that we have. And I think we gloss over that. We kind of think about the because the CON process is the more public thing out there. But there's a lot of conversations that occur at that table that we want our people to be part of.
So the education between what's happening in ambulatory surgery centers and the members of FIPIC.
Yeah.
You have a lot of community people. You have advocates on Public Health and Health Planning Council. You have hospitals, and you have surgeons. You really need the average person doesn't understand the medical advancements that's happened, and they've happened so quickly that people don't even understand. Now, I had someone from the legislature say, "Well, ambulatory surgery center can't do X, Y, Z." Right. And I was like, "Have you been in an ASC in a while?
Yeah.
We need to do that."
Yeah.
And so I think that's also something that we've raised with all of the members. You need to invite people into your centers to show them and be proud of what you're doing for your patients.
At all levels of government.
At all levels. They have to see it.
Yeah. And so that kind of morphs into the last conversation, which is just encouraging people to be part of the state association. And one of your passions is not I can get the directors of nursing and the administrators there. We can work on that, but getting the doctors there is a problem. And so talk about the value that we bring to the table here. You've been with us for, what is it, 5 years now,
5
something
years.
like that. And how do we get those last couple people that we need to be attending these meetings here?
Right. Well, John, you actually brought up a good something that's happened recently, where a newly approved center, didn't know all the ins and outs and what's required. And I think that is something that the doctors and the owners of ASCs really need to be involved in. Yeah. And we've started, today was our first association meeting, or conference that we've had, that we had 3 physicians that are pillars in their community. And not only did they want to come, but they're all going to reach out to other physicians to say, you need to be here. Right. You need to hear these discussions, because there's things that you need to actually learn and influence. Yeah. And that's something that they're getting engaged in. We've also started a new society, right? The society, the first thing I said was, you have to come to this conference. You need to be part of this conference and learn from each other what's going on. Yeah. So we're really going to try to make a push. I think this year we had the largest number of attendees, the largest number of vendors, and we hit a new one, which was we also had physicians. Yeah. So I think this association, I can't say enough about what's been growing in the community. Yeah. And really growing the passion that's here.
Yeah, I was up until 1:00 in the morning because people just don't stop talking together, and it's not, how's your dog doing? Yeah. This is deep conversations about the future of the organization, and and it's been like this. By the way, that's nothing new, but you got to put people in the room in order to have that conversation. And of course, COVID put us a little bit behind, but now we're back, and there's a lot of opportunities out there for our listeners to participate in this. By the way, my company, Ambulatory Surgery Strategies, is a member of many state associations across the country. We pay less here for the membership alone than we do in virtually all the other states. And of course, we're happy with that as an association. We're making good money. I'm on the board also. And, we're making good money. I mean, we're paying the bills, let's put it that way. So this is a value that
I can't imagine, why you would not want to do that. The conversation, I pushed to do the Article 28, discussion yesterday, and I got a little bit of pushback from some people who said, well, everybody knows the Article 28 regulations. Why do you have to talk about it, John? And so I fought for it. I got it. And then when I was writing the speech, I'm realizing that I know the rules, but I don't know the exact wording of some of these rules until you research it. And there was like shock faces when they actually saw the wording of those regulations and saw that out there. So those things that we take for granted, that we think we know completely, we need to delve deeply into and make sure our members are the most educated individuals about what our regulatory environment is, and actually all other aspects of it. And that's what we do here.
One of the things I think that we did the first year we started working, Capital Health Consulting started working with the association, was we brought the director over the Diagnostic and Treatment Centers and Hospital Surveillance Program that oversees ASCs and is, involved. And I think something that I'm learning from some of the surveyors out there is a lot of the surveyors for DOH, there is no longer a training academy.
Yeah.
So we used to have a surveillance training academy when I was in the Department of Health, and that kind of went away during the former administration. Yeah. And I really think it's something that the departments were talking about.
Yeah.
So it might be a great idea if we could actually bring a surveyor for ASCs from each region to come to our conference so we can hear, because we're learning that, for instance, some surveyors are asking for cultures of ORs, right? We just found that out.
Yeah.
And John says,
one of our clients, actually,
And John says, what? I've never heard of that before.
And we've opened 4 centers in New York in the last 18 months that question never came up.
So that's one of the reasons.
And thank you, by the way. You're not admitting to it, but you were very instrumental in making sure that was dealt with. Thank you so much.
Well, thank you.
Yeah.
But I really do think that's an issue that we have to raise as an organization, because then I can pump it up to the Department of Health and I can say, you have some inconsistencies here in your own quality assurance. What's happening between different regions? Let's make sure there's a standard.
Yeah.
And that's something that I think the training academy going away, that actually has caused some of that problem for the department.
And especially if we're willing to pay them the cost for the transportation and things like that to come to these conferences. I think that's a great idea. Ambulatory Healthcare Strategies actually has, former DOH surveyors on it who know all these new people out there who would love to invite them. As a matter of fact, we wanted them to come to the conference. We weren't able to expedite that. But, I think, and speaking to these surveyors, now that they're friends and they're no longer, they're no longer the surveyors there, we get, we see what their frustrations were. And, they were relatively happy, working in that environment. And they know that environment, what they need now is, that they can work with their colleagues to make sure that they get all of that knowledge that they're going to need to be, fully knowledgeable about it in the future.
We have to be careful with that, because there is the public health law for surveyors that have to be very, we have to be mindful. Surveying is a tough job. I actually had to go out in everything from acute care down to ESRDs, down to assisted living and nursing homes. And it's a really, really tough job. And the state's having a lot of problems getting good staff, like everyone else, especially getting the nurses. So we heard from Dr. John Morley. He has over 500 empty positions. Nurses are the biggest issue. So the same, pain points that the ambulatory surgery centers have and the hospitals are the same pain points they have as well.
It's actually worse, probably, because they just don't have, it's not as sexy a job as our surgery centers and even the hospital jobs are.
Used to be, when I left, when I was recruited out of the county government to go to the state, I actually didn't want to go. I'm thankful I went. The experience was wonderful. But it's not as much money. The benefits aren't as lucrative as they used to be.
Right.
They've cut them, year after year after year. If you're a tier 4, God bless you. I'm thankful I am. But there's now tier 5 or 6 or 7. So it's a hard job. It's a great new job. I'll put a plug in for the department. It's a great new job for someone that's gotten a little bit of clinical experience, really wants to understand and learn rules and regulations. It's a great new job for people in their 20s. Before you start to have a family, it's excellent. So I'll put that plug in.
Well, and I think we want to help provide whatever training. It's not even that we would be doing the training ourselves, but being able to give information about what it is, so that when they walk into a center like our ambulatory surgery centers, they're not shocked at what they see or the types of procedures they're doing. Because I feel that way sometimes, that you're doing like total hips in the surgery center. Yeah. I mean, by the way, I'm a surveyor, as you know. With one of the accreditation organizations. I watched my first hip, I think I told you, about a year and a half ago, and except for the noise, which was kind of interesting, it was shocking to me that woman walked out of there.
It's amazing.
It was amazing, and and I asked her, as a surveyor, I was asking, so how was your experience? This was wonderful. I didn't have any pain. I didn't have to go to the hospital. My husband was there, right with me after the procedure, within 10 minutes of the procedure being done, and I was nearly in tears thinking about my mother 20 years before, and she's a tough cookie. She wanted to be out of that hospital, and she would be a perfect candidate because she didn't want to be in that hospital, but she was there for 7 days, and it was the same procedure. So that's what we are doing. That's the excitement that we have to generate, and those are the things that surveyors need to understand. We're not just doing cataract surgery and GI, upper and lower anymore. We're doing much more complex on much more sick patients. So
Right. It's excellent. The future is great.
It is.
For ambulatory surgery centers. I think the future is great for healthcare.
Mm-hmm.
I think, we cannot continue to do the same thing, right?
Yeah.
So that's the tough discussion and the education we're trying to share with not only the Department of Health, but also with the legislature.
Yeah.
They don't understand.
Right.
And the general public still isn't up to speed on all the things that are happening.
Right.
And then the other thing that I think we really have to work with is we need to work more together with the Health Plan Association and have some better conversations.
That's a very good point.
Physicians, they have medical directors that sit on those boards.
Yeah.
We need to have them physician to physician.
Right.
So I think that's going to be one of the things I'm focusing on as soon as this conference is over.
As always, Lisa, I'm going to make sure that this is our last interview at the end, because, the nice thing is with everything else we've been talking about, it really hasn't all been negative at all. It's good to end on a very positive note, and you've been wonderful about that. Thanks so much for joining us.
Thank you. That's very sweet. Thank you. I appreciate it.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ASCPodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.